Jadi settingannya kita tahu sekarang lampunya nggak boleh di atas kepala kita. Jadi backlight ya. Nah, terus yang kedua, hijau itu.
Afternoon, everybody.
Hello, Kuya Maki.
Halo Maki.
Hello,
How are you?
good afternoon. I'm okay.
Okay, fine.
Linda, are you there?
Opo.
I cannot show my scrubs.
Oh, you're going down. Like the other day naman.
I cannot zoom down.
No.
Wait, I'll wear my Olympus shirt.
Olympus is okay, I think.
No.
So we are waiting. We have 14 participants already.
Okay.
Alan, looks like you came out of surgery again, huh?
Hi, Prof.
How are you today?
Hi, David.
How are you today?
Oh, David.
Hey, Barlian.
How are you?
Not bad. You? What are you doing with the mask?
Yeah, because it's a lot of people here around me.
Oh, really?
Yeah. Not so many, but I was.
Hopefully Indonesia will be. Otherwise, we cannot travel.
You cannot come to Bali, huh?
Yeah.
No?
Terrible. Yeah, not so good.
Yeah. Yeah, but actually, if you come, there's nothing to see now. In moment is quite okay, but in my hospital is no COVID since more than 3 weeks, 4 weeks.
So that's good. Yeah, I think probably it's under control. There was a bit of positive case when the people start to travel for the Hari Raya. Huh?
Yeah.
Now it's more than almost 1 month. So the number went really going down, I think.
I hope so.
Hopefully will disappear the virus. Otherwise we are stuck here forever. Because the vaccine, they are not going to do the vaccine. Too many problems with the interactive antibody and sideway. Too many problems.
Yeah, I'm not sure with vaccine. I think there's a lot of problem for this.
Yeah, there were a lot of problems in developing it.
Yeah, we must stay to protect ourselves. Yeah,
No choice.
no choice.
No choice what to do. No choice. What are we doing today? Actually.
Hey, good afternoon, Davida.
Good afternoon, Anil.
Hey, Anil. How are you?
Hey, how are you, man?
Where are you?
Itunya deketin dikit bisa.
Where are you?
Oh, I'm in the hospital, Davida.
Why?
Like a laborer.
Very dangerous. 16,000 cases in India today.
Yeah. But then luckily enough, the damn fatality rate is not high. So the rate of, I think, infections is high, but the fatality rate is low.
Yeah,
So
because,
not too bad.
Yeah.
Not too bad.
Yeah.
You have to keep looking at the small positives.
Yeah, but for now, they mostly look at the number. Actually, I agree with you. Mortality is very low.
Yeah.
I think the virus changed it a bit.
Yeah, I don't know, man. There's so much about this virus that we don't know. We just
Yesterday in US, 39,000 cases, 40,000 cases yesterday. But they are full. In Texas, I was reading the ICU hospital all full. They are.
Yeah.
But it's different. I think in US, more obese people. In
No,
India,
we
more,
have-
yeah. Also, the mean age maybe, yeah.
we also have enough number of obese people here, but mercifully we don't have many patients in the ICU and many patients in hospitals so far, at least, fingers crossed. So I don't know.
They're saying that the US virus is the European strain. It's more virulent, supposedly.
It's more, yeah, it's more virulent. Yeah, but actually, this was the initial one. In Europe, at least in Europe itself, the behavior is a bit different because suddenly the number of infection, the number of testing going up, but the number of infection and number of deaths going down dramatically, even though people go to the beach, gather more and more and more.
Yeah, that's right. Good afternoon, Rolf.
Hey, Rolf,
Hi, how are you, Davide?
not too bad.
Not too bad.
Hello, Love. How are you?
Hey, Dubai today, they have a big sport event. What a sport event in Dubai.
Like,
I don't know. I saw some water sport jumping around with the hydrojet in the news.
so you are better informed than me. I don't know about.
Oh yeah, there was a big, huge event. It was in everywhere, TV, newspaper.
Mhm.
You know
On the
this
beach.
acrobatic new hydrojet, jet ski, all this.
Good.
Okay, that's good.
The water is something like 36 degrees, so
Oh yeah, now start to be hot, huh?
it's very hot.
Wow. No, but
So one more very big webinar coming in from Singapore, Davida. Your ELSA thing in the time of pandemic or something. I saw it on social media. So are you doing that?
Boss, wala naman.
I don't know which one.
The ELSA webinar, you know, in the era of disruption or something.
Oh no, this is our conference in September. You can see behind me.
Yeah. Oh, okay.
This is
Oh.
our ELSA conference because supposed to be the World Congress in Japan, but the Japanese actually initially they postponed, and after that they want to change to 2024, 2025. They don't fix. So practically we discuss with them. So we split ELSA, and we will do our online conference. So we will have actually I was talking with Rolf if we can have a joint also session. I don't know, this year at APHS we are not going to have any conference?
No,
Why we don't do online? 1 day, 2 days?
I proposed before, but I think it was somebody called Davide who didn't want so.
Okay, but anyway, we have a 7 invited lecture. We have 16 sessions from morning to evening, and the company are very happy. We have a virtual exhibition. I think it's feasible, financially viable, and we have a lot of people join us. We almost got almost all Linda is here, almost all the company. They will have their own, some they have a lunch symposium, like a webinar. So we are going to have 16 sessions. I think, Rolf, you got the letter?
Yeah.
I think you will be chairing with the inguinal hernia. Alan will do education. Barlian will do something else. Maybe me and Maki we will do the ventral hernia with Daniel. Maybe we'll go about new stuff. So it will be quite interesting. Will be 8 sessions per day with the two or 3 rooms concurrently. So we almost finalize everything. And I must say all the company are in, at least the big one. Medtronic, J&J, Olympus Store, all. Bard, also even Bard.
We have to discuss with Toon because he sent me a message this morning only.
I
What
saw.
about my conference in 2021? So I answered him that was supposed to be in Shanghai.
No, supposed to be Vietnam and Shanghai want to postpone, and actually Tun was keen. Tun say he was keen to move to 2022, 2023, 2023, actually.
But still, he has sent again a reminder to me this morning.
Because there
I
was
thought it was clear.
official communication.
No, I texted with him before, and he said, no problem, we can postpone.
But I think we need to have a kind of written. We need to have a written document about China. That China will do 2021. For now, we have everything on the WhatsApp, on WeChat, but nothing.
I will send a letter to Tang to ask officially and to tell us exactly when he wants to do it.
Yeah,
because
and
it
then
was only on WhatsApp so far.
Yeah, then we can line up. Okay, 2023 will be Vietnam.
And
2 minutes to go according to my watch.
If you want to join ELSA and APHS in this conference together, we can, of course, discuss it. Whether we put the logo of APHS as well, I don't know.
There are two possibilities: or do this, or do do end of October or November, because the situation will be the same. We can have a small APHS conference on the same kind of format, couple of days.
I don't think that any physical meeting will be possible before mid of 2021.
That's why I say, if we want, we can just do like a huge webinar with 2-3 rooms. We can use even the ELSA account, everything. I don't think there is an issue.
No, my feeling is we need to, I think, register presence of the APHS online this year. So maybe we can do, something as well, perhaps half a day or 1 day or with the ELSA.
I think it's possible to, because in the ELSA,
we need to do something.
Yeah, it's only 1 or 2 sessions. It's too little. But I think 1 day event on one Saturday from 10 o'clock to 4 o'clock with 2 rooms, with, I don't know, 4, 5. In 1 day, you can do 8 sessions. I did more than enough. We can have some American, some European. I think if you are keen, we can work on it.
Can do. I think we must do something to register our presence, that we are still afloat.
Yeah, I think that's why the idea of ELSA to engage the community. Correct. And I must say, even yesterday, I just sent out, Alan, I think received it. We have 600 people, 51 countries. We have people from, we have 5 people from Mexico, Ecuador. I know we have 40 people from Pakistan. And we have, 12,000 hit on Facebook. 9,000 people coming to view Facebook. So I think it's possible to do. And when I do the poll, hernia is still 22% of the participants want to have hernia webinar. I think if you just Rolf, if you think that we want to do, is this possible to do? We can use the same format with virtual exhibition. We do 1 day, 1 Saturday.
Okay, time's up, my friends.
Yeah.
So who's gonna take it? I think Rolf, will you sort of welcome them, in again today, please, and then we can kick off.
Sure.
Thanks.
No problem. So are we online now?
We are online, Rolf.
Okay. So good afternoon, all of you. So this is the 3rd day of our APHS Hernia Essential course, the basic online course. I hope you enjoyed the last 2 days. We had good lectures and a lot of discussion over the last 2 days. Now today it's the last day, and we have 2 main topics to cover today. This is the biologic implants means all the meshes, and then also the choice of procedure. So we do have Professor Davide Lomanto with us today, and Ellen, you are covering the meshes, if I'm not mistaken, right?
Yes, okay.
After that, we will have the question and answers, the quiz, which you have to complete. And then we will see, hopefully all of you will pass and will successfully finish the first basic online training for this fellowship. So I think I will hand over to Ellen.
Yes,
Yeah,
thank you, Ralph.
can I just say something again before we start? We have had a tradition, Rolf, as you know, that the top two or the top three scorers in the MCQ section get
Yes.
a, a complimentary life membership to the APHS. So do we still
This is
have
very
that
generous from your side, Anil. So if this tradition can continue, I'm more than happy.
Yeah, so we need your permission, Rolf, before we can declare that, you know, for this particular edition of the MCQ too.
Granted, without any doubt.
Oh, wonderful. Right. So our participants have one more reason to look forward to the MCQ. Thank you, Rolf. Okay, so who's taken up the first one? Kuya Allen,
Yes, thank you.
it's all yours.
I think the first lecture is about prosthesis and fixation, and I'm the one in charge in giving the lecture. So I'll start off, Anil.
Yes, please, Kuya.
So anyway, good afternoon. Welcome again to the last session of the three-part basic online hernia essential course of the Asia Pacific Hernia Society. The first lecture will be about prosthesis and fixation. This is part and parcel of the three series of the hernia essentials, and we'll be covering basically this afternoon for ventral hernia. So anyway, my topic is about prosthesis and fixation. Can we put on the slides first? Okay. The first slide, please. Can we go on to the first slide? Okay, thank you. So the first, I'll be talking about prosthesis and fixation. If you look on ideal mesh properties, you would want always to look at limiting the foreign body response. Obviously, before we go to the lecture, let's answer first the poll. Sorry for this one. Can we ask all the participants to answer the poll? Is the poll ready now? Okay. So the first question of the poll is, it is essential to know the basic characteristics of mesh in hernia repair. Yes and no. And number two is, which type of mesh do you prefer? Absorbable or non-absorbable? Please answer the poll. Do we have the answers? Can we post the answers to the poll? So anyway, for the first question, it is essential to know the basic characteristics of the mesh in hernia repair. 100% said yes. And in which type of mesh do you prefer, absorbable or non-absorbable? 62% answered non-absorbable and 38% answered absorbable. So anyway, I'll go to my lecture. Okay, let's close the poll. We all know that if you're looking on an ideal mesh, these are the properties that you would want to look at. The mesh should limit the foreign body response. Obviously, you don't want any form of rejection. You don't want that mesh to be rejected by the body of the patient. You want to prevent and control post-operative or even operative infection, because then again, then you'll have rejection again of your patient. And then, of course, promoting tissue ingrowth and vascularization. And obviously, you would want to have you want to achieve a physiologically relevant mechanical property in your patient. So what are those characteristics? If you're looking on the mesh, you would want to look on 5 basic characteristics. One is the weight. Second is the pore site, the filament structure, mechanical strength, and obviously the elasticity of your mesh. So let's take them one by one. For the weight, we all know that you have basically when the first prosthesis was introduced a long time ago, you have the heavyweight mesh, the medium weight mesh, and obviously in the past few years we have now the popularity of your lightweight mesh. We look on what are the evidence on this one later on. I'll explain it to you later on. But let's just look on how do we classify now the meshes as heavyweight or lightweight. So for heavyweight meshes, you have at least 90 grams per meter squared of material in that mesh. And for medium weight, between from 35 to 90 grams per meter squared. And lightweight meshes would have less than 35 grams of material per meter squared of that mesh. Now, if you look on the pore size, the proposed classification of the size of the pore would be 1 millimeter. So for greater than 1 millimeter, would always say that it's a large pore mesh, and for less than 1 millimeter size of a pore, we call it a small pore size mesh. And we look again on the evidences of this one later on, and I'll explain it in the last part of my lecture. For filament structure, you have 2 types, the monofilament and the multifilament. The significance of having a monofilament or a multifilament, if you have a multifilament structure of that mesh, you increase now the site of where the bacteria can attach itself, thereby increasing the risk of infection in that mesh. It also increases your inflammatory response. So basically, if you have a monofilament type of filament structure of that mesh, the site of where your bacteria can attach itself is lesser. Hence, getting a lesser degree of infection in those types of meshes. So for mechanical strength, we all know that for the normal intra-abdominal pressure is between 8 to 12 millimeters mercury. For a high intra-abdominal pressure, you have at least 20 millimeters mercury. And the highest intra-abdominal pressure that you can gain, especially when you're coughing or when you're jumping, you're exerting that effort, the highest pressure would be about 171 millimeters mercury. Why is this important? Because if you look on it, we should have a mesh that can actually cover up and can control that intra-abdominal pressure that you're exerting to. So by Laplace law, if you look on the maximum tensile strength that is required in the prosthesis, you need at least 32 newtons per centimeter. And if you look on the composition of the older heavyweight meshes that we had at the early part, it's nearly about 100 newton per centimeter of that mesh. Hence, if you're looking at it, we're actually over-engineering all the meshes that we had, the meshes that we had early on. So the idea now is to create or to produce more from middleweight to lightweight meshes. Hence, the popularity of a lot of lightweight meshes out in the market, and that's not the one that almost all of us are using now. But later on, we look on the evidences of this one. So for elasticity, mean elasticity of your abdominal wall is about 11 to 32% in all directions, either horizontally, obliquely, or vertically. Your heavyweight meshes would provide at least 4 to 16% of elasticity. So even for meshes that are quite stiff, they still provide for some form of elasticity. And lightweight meshes are known to have at least 20 to 35% of elasticity. Even your suture, if you try to stretch it, you have some form of elasticity in this material. So the lighter and the more elastic prosthesis, it's the more ideal prosthesis that we would want to have in our patient. For the absorbable prosthesis, in your biologically derived prosthesis. For non-absorbable meshes, you have your polypropylene, which is the most common type. In the lot of our operating rooms, especially in the Philippines, this is the most common mesh that's available, readily available in our operating rooms. You have your polyester or your PET, polyethylene terephthalate, and your EPTFE or your expanded polytetrafluoropolyethylene. Quite a busy slide. It's just some of the examples that we have for your non-absorbable meshes. These are the meshes now that's available for out in the market right now. Some of them are available in the Philippines and some are not. I won't go into each one. So for absorbable prosthesis, it decreases actually the foreign body and the immune response. It's used more on contaminated fields where you have, when you operate on a patient and you're thinking of putting a mesh or a foreign material to cover up for the defect, they said the best choices would be to use your absorbable prosthesis because it decreases the incidence of rejection of that material. And of course, it decreases the chronic pain, the incidence of chronic pain and formation of fistulas later on. So again, some prosthesis that it's available in the market. I wouldn't go into the details. So for biologically derived prosthesis, fundamentally they're extracellular matrices that's obtained from a decellularized living tissue. It functions as an active scaffolding for native cells for it to populate the mesh for the remodeling process during the wound healing process. So it may be xenogenic, meaning coming from another animal, or allogenic, coming from the same species. For composite and combination, it's a combination of a non-absorbable suture and an absorbable material. Therefore, combining mechanical handling properties of your polypropylene or your PET while reducing the mesh weight. A lot of these examples are created actually for laparoscopic IPOM repair. So just a few examples of the biomaterials, the combination of your composite materials. So for coated prosthesis, you have created for intraperitoneal mesh placement. It is aimed to minimize adhesion on visceral side. We all know an IPOM repair, laparoscopic or open IPOM repair, that the mesh is always exposed to that visceral side. So the aim of a coated prosthesis is to protect that mesh and to protect that visceral organs, not to have any adhesion on the site of that mesh. Knowing that in the future, if you don't have a coated prosthesis or a protected mesh, for formation of abscess or even fistulas later on can occur in these patients. So the aim is to minimize your adhesion on the visceral side, and the prosthesis actually are coated either with biologic, chemical, or physical treatment of that mesh. So coating, the different coating that you can see on that meshes are mainly composed of either collagen, oxidized regenerated cellulose, carboxymethyl cellulose, and other collagen compound like human and animal origin. So these are just some examples of your coated material, and the most common is your Sepromesh, which is available. Proceed, which was available early on, maybe 10 years ago, but was now taken out of the market because of incidents, a very high incidence of recurrence. Actually, we had one patient where I think it was 8 or 10 years ago, a very popular governor where we placed a Proceed mesh. And after 5 years, the patient came back with with a recurrence of that hernia, of that ventral hernia. Thigh mesh is one type of a coated prosthesis, secure, and of course, Zenapro from one of the companies that's not available in the Philippines. Anyway, for pore size, looking on either a small pore or a large pore size, what's the evidence on this one? The effect of your pore size alone, if you look on the clinical outcomes, has not been investigated in clinical trials. So basically, there's no recommendation that can be made, even if you look on the different hernia societies' recommendation. So for mesh weight, if you look on recently published meta-analysis and randomized controlled trials, they do not support the contention that lightweight meshes actually are beneficial in groin hernia surgery, and if they're associated with better post-operative outcomes. Although, historically or for personal experiences, some would say that for if you're using a heavyweight mesh, patients would sometimes feel, the type of foreign body attached to their inguinal area. But then again, there's still no evidence on meta-analysis and randomized controlled trials on this one. So there's no clearly defined weight limit for lightweight meshes and heavyweight meshes. Therefore, the effect of weight differences alone on surgical outcomes is quite unknown and quite not clear at this point in time. Migration, the issue of migration, we all know that placement of a foreign body inside the patient would have always the risk of having a migration, especially for meshes. So mesh-related complications, including your erosion and migration, should always be considered every time your patient comes back with a complaint, especially patients coming in after surgery, even years after the first surgery. We should always look at it as one of those complications in our patient who had undergone a mesh placement on this patient. For mesh shrinkage, we all know that meshes would have at least 20% shrinkage rate. So you have to account for the size of the mesh. If you're thinking of a exact size of the mesh to be placed on, for example, for a 5 centimeter mesh, 5 centimeter hernia defect, you should account for that shrink percent. So that the mesh that you would want to cover up everything or all the defect and would account for that 20% shrinkage rate. For fixation methods, because we're putting a mesh, fixation is secondary again now in placement of mesh, especially if you're doing your IPOM or your IPOM repair. So suture fixation is the most common. We usually do it in a full thickness one. Partial thickness fixation is also done either by metal fixation. Absorbable clips can also be used. And of course, now the popularity of using your tissue adhesives like your fibrin sealant and your cyanoacrylate or your super glue. So examples of this one would be your Protac, coming from one of our friendly company that supports our surgeries. So Protac is a single-use multi-fire 5mm instrument with titanium coil. So we should always look on the characteristics of our instruments and our fixation methods. So another one would be your Absorbatat, which is a partial thickness fixation again, but it's absorbable. It's a 5mm spiral shaft and easy to use with an easy to use design. It's a screw-in top with a 5.1 imprint. Total length is 5.1 with a 4.1 inserted length of that method. And of course, your fibrin sealant, examples of which are your tissue coil, your quick seal, or your Eviseal. For open hernia repair, a traumatic mesh fixation is being now introduced using your fibrin or your glue in open inguinal hernia repair, and suggested to reduce early post-operative pain, even for laparoscopic approach. So let's go on laparoendoscopic hernia repair. In almost all of cases, in any type of mesh fixation, especially if you're talking about PEP, evidence would show you that fixation is unnecessary. You also have your traumatic mesh fixation, like your talkers. We recommend using fixation only for large hernia. If you're using your European Hernia Society classification, it's your M3, which is more than 3 centimeter direct hernia defect, either using your TAPP or your TEP. So go back on recommend on this one. So looking on polypropylene, what's the take-home message for this? So take-home messages would be the most common materials that are being used are your polypropylene, your polyester. They're the most basic material for hernia repair, and they're also the cheapest out in the market. If you're to choose between monofilament and a multifilament, you would rather go for a monofilament because it decreases actually the incidence of infection in your patient. So reduction of the material of that mesh with a large pore size are more favorable in your patients. Combination meshes will minimize adhesion and would decrease the incidence of your fistula later on in your patients. And coated meshes reduce adhesions and may provide local delivery of growth factors and drugs. I think this is my last slide. Thank you very much. If you have any, maybe we'll have our open forum after another lecture. Anil, Rolf?
Yeah, there are no questions. I cannot see any questions on this topic so far. I can only see some reminders to put questions, but no actual questions there. So to put a question instead of the participants, what would you prefer, a tacker or sutures? Knowing that sutures, specifically transfacial sutures, have the strongest fixation force.
If we're talking about ventral hernia repair, I do a lot of stopper ribs now in a retrorectus fashion. So I don't put any tackers or any transfacial suture. But during the early practice, the way we do it is do a transfacial suture with tackers, a combination of both. But then again, having the experience of doing IPOM before and then a retrorectus approach today, the pain on patients are quite higher on the IPOM side. So nowadays, I shy away from using a transfacial suture and tackers. But it's a different view now on inguinal hernias. Inguinal hernia is quite different because I don't use any tackers anymore. I'm more keen on doing TEPs. My first attack would always be TEP, depending on, of course, the situation of the patient. But for TAPP, to close that fascial, the peritoneal defect or that peritoneal flap, I usually suture it. So with your question, it would always be dependent on what kind of hernia.
Okay. Next question would be, we heard and we have seen day before yesterday the use of self-gripping meshes.
Self-gripping, the pro-grip one. I have a very limited experience on pro-grip because we just had it a few months ago. What we're using now is the pro-grip for inguinal hernia. What we're trying to get now is the pro-grip for ventral hernia repair. It's a little bit cumbersome to do, especially for the folding up when you're doing your inguinal hernia repair. There's a special way of folding it up and try to unfold it inside the abdominal wall. Our experience, our limited experience, quite promising. It's stuck in there, but the problem with pro-grip is if you're starting off and then you accidentally attach it to the wrong side, it's quite difficult to remove. So still the experience is quite new. But then I think even having said that, I think it's promising, the usage of a self-gripping mesh.
Yeah. And my last point would be the overlap of meshes, given that different types of meshes have different degrees of shrinkage.
Yes, I agree. I agree with you, Rolf. Uh, that's why we always have a lecture on the mesh. Primarily because of we always teach our students to always look on the characteristics, to always how to do that, to educate ourselves on the characteristics of the meshes, because each type of meshes would have different shrinkage rate. Some would shrink 30% of the time with a certain type of mesh. So knowing how much shrinkage you'll have or you'll expect in one mesh, you would have now a better gauge on what's the size of the mesh that you would want to put in a certain type, certain size of hernia defect.
Yeah, now we have two questions coming up. One is from Kevin Appeles. He wants to know, what is your recommendation for a large inguinal scrotal hernia? Would you advise to fix the mesh or not?
For inguinal, for lateral, so this is an indirect inguinal hernia. For large hernia defects, we don't do anymore. Even if you look on the recommendations of the societies from the European Hernia Society or your American, even for the recommendation of the Asia Pacific Hernia Society, the recommendation is always for your direct inguinal hernia defect. So more than 3 centimeters, you would want to fix. Uh, in my own practice, I usually invert the transversalis fascia and tuck it, fix it at the Cooper's ligament, and fix my mesh on 3 points. One on both sides of the hernia defect of the midline, and one on the lateral side. Taking note of that ilioinguinal, the iliopubic tract. You don't want to put any tuckers below that iliopubic tract.
Yeah. Maki, any additional comments? You wanted to say something on this topic? You have to unmute yourself.
There's another question in the chat box regarding the use of mosquito nets as mesh for mesh repair. And basically, this has been tried in a low resource setting. The group of Kings North, David Chen, they tried this in Africa during their mission. And according to them, it works. But again, the biocompatibility of these mosquito nets, we don't know exactly. The tensile strength as well, we don't know exactly. So maybe in a very low resource setting, definitely you can use mosquito net. But meshes now are not that expensive as compared before when we were residents. So I guess it will be more affordable now to the patients.
I had the I had the I had the chance of talking with Philip Chastan. He's the inventor actually of ProGrip years ago. We were in Shanghai, I think, and I was talking with him, and he was the one who was saying, you have to remember, mosquito nets are made up of polyesters. So even if you look on the composition of the meshes that we have right now, we have polyesters and polypropylene. So if you look on mosquito nets, the idea of using a mosquito net is actually good. I agree with Kuya Maki that in areas where you really don't have, there's a dearth of materials and economics and financial, the finances are quite a question. Maybe yes. We've heard a lot of Indian surgeons doing also mosquito net. There's a paper, Anil, correct me if I'm wrong. There was a paper a few years back about an Indian surgeon using mosquito nets as a mesh for inguinal hernia.
I mean, quality mosquito net meshes are definitely good meshes. However, they have no medical product confirmation. They are not approved. Now, as you have heard yesterday and day before yesterday about the litigation against non-qualified meshes, specifically in US. Here in my place in Dubai, we wouldn't be allowed from the regulator point of view to use such meshes. So I would not recommend to use them just for medical legal purposes. Forget about the quality of the mesh and whether it is as good or not. As long as it's not FDA approved, as long as this has no permission from the bioengineers in your country, I wouldn't recommend to use those. Really only in absolutely low income countries where there is perhaps or certainly much less medical legal issues as compared to the more advanced countries. So I don't think there is a chance to use such meshes in Japan, in Singapore, in Dubai, or
the Philippines.
yeah. Yeah. Okay.
Thank you.
I think we should move on. Thank you very much for these questions. Always interesting to hear the different opinions.
There's a question on YouTube, and the question is, for ventral hernia repair, what type of tucker would you use to avoid dimpling on the skin? Tucker would you use to avoid dimpling? Tuckers don't usually produce dimpling on the skin. The dimpling would be if you use a transfascial suture and then pull it up. To remove that dimpling, you just pinch the skin and the dimple will disappear, if that's what you mean. Because tucker would usually be placed underneath. Okay, if there's a dimpling, then obviously the length from the peritoneum to the skin is quite thin, so you have to be very careful. If you have a dimpling, it means the tucker went through and through the skin. Then you have now a higher incidence of infection because you have now a protrusion of that, material outside of the skin. Does everybody agree? Kuya Maki, Anil?
Yes. I think the dimpling thing can occur only in very thin patients in lap groin hernias, but certainly not for ventral. If it's the tucker that we are talking about, the traditional tuckers are actually quite long. So that's why they cause some bit of dimpling, because for Asians and thin people, they go through and through, as Alan mentioned. But nowadays, the profile of the commercial tuckers are not that long, except for one. I'm not allowed to say which one.
There is one more question now, also an interesting one. Can expired meshes be used?
Can we still
that would also implicate, can expired meshes be re-sterilized? Ellen, you want to take that?
I would take it as like this. The incidence of medical suits right now are quite, going high, especially if you're living in the United States, Dubai, or even Singapore. So if you have an expired mesh, I'd rather use a new mesh than going for an expired one. If you use an expired one, the next question I think would be, if I had an expired mesh and then you regas it, would it be possible again on your patient? Is it possible to use it again in your patient? I think with the incidence of a lot of medical suits and everything, it's better to protect ourselves too. So I'd rather go for a new batch of meshes that are not expired. And, as it is, there's a lot of things that are attached to a mesh, like your infection and everything. So you wouldn't want to expose yourself again on the usage of an expired mesh. That's how I would like to take it personally.
I mean, here in Dubai, we are not allowed. We are forced to send those items back during the check of our stores. All expired material will be sent back to the company. What about India and Indonesia, Balian? Would you use an expired mesh? Let's say it expired yesterday.
It's the same. It's the same like yours, because the expired things, if someone know about it. This is very dangerous for us as a doctor. We don't use it. We don't use expired meshes.
Anil, in India?
Your question does not arise. You know, I mean, you simply cannot justify placing a mesh that has expired into a patient, because, like you mentioned yourself, there are so many medical legal issues that keep cropping up from time to time, and that scourge has actually spread to this part of the world as well. So you have to save your own backside as a surgeon, you know, at all times. And doing something like this, like in fact using, you know, a mesh that has expired is I think exposing yourself to a lot of potential trouble. So best not to use it. Send it back to the company.
Remember, everyone, that a sticker from the product has to be placed into the file or in the computer system, so that this is traceable even years after implantation. And if it comes to the light that that was expired even years after, if you have a mesh failure, whatever it is, infection, rupture, migration, you will be exposed to a serious accusation. Yeah. So I cannot recommend this.
Yes, so we don't recommend it. Yes.
I think there's one more question about mesh infection. I would like to postpone this question for later, for the next lectures we will see. Anybody disagrees? I think we should go on with the next lecture.
Let's go.
Yeah, yes, sure.
Let's move on.
Yeah.
Okay. Thank you.
Davide, are you ready?
Yes, I'm very ready. I need to get the permission to share my screen. I think, anybody behind to allow me to share my screen, please?
Cherry?
Okay.
Yeah.
Coming.
You can share your screen now.
Yes. Okay. 1 minute.
You got it?
Share now.
Yeah, I'm ready. Okay, we are here. Okay, thank you very much. Thank you, Anil. Thank you, Rolf, Alan, for organizing this course over 3 days. A very big commitment, and I hope.
Before, David, sorry, before your lecture, we'll post first the poll questions. So we have can we post now the poll question, please? Okay. For the lecture of Professor David Lumanto, we have 2 questions. So the first one is laparoscopic intraperitoneal only mesh repair, or IPOM, is the standard procedure. A, yes. B, no. For number 2, use of coated intraperitoneal mesh is safe. Answer is A, B, no. Participants, please answer the poll.
Okay, then we can move on with in the meantime, the question that I think we can move on with the lecture.
We'll post the answer.
We'll post the answers later? Oh, now, okay.
Yeah. So 63% for the first question answered no. Laparoscopic IPOM repair is the standard procedure. Number 2, for the question number 2, 92% said it's safe to use a coated intraperitoneal mesh. So David, please, for your lecture.
Thank you very much. I think the poll is quite interesting because it's not a standard, but it's safe to put a mesh inside the abdomen. It's a bit contradicting. Let's clear up some of the doubt. We are talking about ventral hernia. We are talking about patients that come to your clinic with this kind of picture, with kind of abdomen. We know that today, and I reply to the first question of the poll, that we have several techniques from the classical open to the IPOM, IPOM Plus, ETP, Tesla, Milos, association of component separation, TAR, Botox, up to the robotic. What we can say that for IPOM, IPOM Plus, we have a million of cases and we have million of study. For the other technique, this is still under evaluation because we still need short-term and long-term study. They show and evaluate the outcome. We have a very few study and outcome that confirm the effectiveness of those techniques in the standard clinical practice. So IPOM is still the gold standard today because of 20-year experience. And even though we know that the mesh can be positioned everywhere, and we do in open, but positioned in maybe laparoscopic or robotic is a different way because we know that somehow in some preperitoneal, retroperitoneal technique, we can have up to 20% of postoperative complication in terms of bleeding, seroma, and terms of reoperation. So do open may be a bit more control than laparoscopic at the moment. So we talk about IPOM means a positioning of the mesh intraperitoneal. The term of IPOM is a bit wrong because intraperitoneal onlay is a contradictory term because we are talking about a mesh that is positioned behind the peritoneum and onlay on top of the muscle. So it's not really correct. We do have guidelines, and you can, most of these are free articles that you can read online. We have a guideline from the laparoscopic and non-laparoscopic society, the European and the SAGES for ventral hernia, and all come up with some kind of definition and suggestion that we will be highlighted during this workshop and this 3 days course. The objective for today is to talk about indication, what are the best patients to select for an IPOM, diagnosis, how to prepare the patient, how to do a nice procedure, correct procedure, how to handle the complication, what is the best way for a fast postoperative recovery. In terms of selection, I think probably patient with the hernia that goes between 3 to 12, 14 centimeters are the best indicated. Hernia that are larger than that, or in which a CT scan show that you have more than 30% of the abdominal content outside the abdomen, they require a different procedure that is not a classical open or laparoscopic repair, in which there is we need to exclude patients with the multiple previous abdominal surgery, with complicated hernia, with the fistula, enterocranial fistula, or wide diversification of the recti. So usually the clinical examination for primary hernia is enough. For recurrent hernia and complicated hernia, I think a CT scan is the best way to do compared to ultrasound. You can see with CT scan, you can do a nice 3D reconstruction. You can plan, you can order your mesh in case you need it. And it is very useful, especially in patients with that are obese or able to detect patients with the multiple occult hernia or different defect in different area, or with patients with previous laparotomy. So you can really have a nice view of the abdominal cavity today with the 3D imaging. We need a bowel preparation? No, routinely we don't need. But we need it only in patients with the multiple previous abdominal operation, with incarcerated, complicated hernia, in which there is a higher risk of enterotomy. In Asia, usually we don't do prophylaxis for DVT, but of course, if your surgery lasts more than 1.5 hours, if patient is obese, maybe you may think about it. It's always good to put a urinary catheter or a gastric tube if the hernia is higher up or lower down below the umbilicus because of the risk of injury. Antibiotic prophylaxis should be used. Usually a single dose, a first generation of cephalosporin is maybe indicated. because we don't know if we can make an hematoma or a simple hematoma, maybe by suturing or maybe a small serosal tear. So I think it's good to protect the patient with a very cheap dose of antibiotics. What about surgical technique? In most of the case, except in lateral hernia, for abdominal midline hernia, they lay out the patient supine, and usually we stand on either right or left side of the hernia. The position usually is the side where we should stand. Usually it's the farthest from the hernia defect. While for subcostal hernia, we can stand between the leg, or for pelvic hernia, we can stay on the right or left. For flank hernia, usually we use a semi-lateral position or partial lateral position. So it's a different kind of approach. The classical step for a repair go from the access to the abdomen, adhesiolysis, reduction of the hernia content, and then a good diagnostic lab to evaluate the entire abdomen, mesh, choice and fixation, or mental cover, and then post-op. In terms of intraperitoneal access, usually the open access is always the good one. Where to position the trocar at least 8 to 10 centimeters far from the edge of the hernia defect. We can use a Veress needle if there is a primary hernia, or we can use a Veress needle in the left subcostal if the patient has previous laparotomy, or we can use an optical trocar, for example, if the patient is obese, like in the video you are watching too, because it gives you a easy control access to the abdomen. We need to be careful, and that's what we say, it's always good to put an orogastric tube, because sometimes with the Veress needle we can puncture organs, in this case the stomach, that is easy to repair, but sometimes it can also be the bowel. So always check your entry point once you put the camera in. The other port you need to be positioning usually on both sides of the endoscope, and to achieve a good triangulation. Usually we work on the lateral side, so left or right side, with the 112 millimeter port in between the ISIS and the costal margin, and the other 2 ports on the lateral side. Important to do a very good adhesiolysis. Using a cold scissor is still the best if you have a bowel nearby, and avoid the use of energy. While if you have only omentum, I think you can use high frequency energy. You can use either bipolar, high frequency bipolar, ultrasonic, or personally, I always prefer a bipolar, high frequency bipolar. We should clear all the abdomen. We need to reduce all the content, because always we don't want to leave behind any small hernia. And we need to be sure that all the fat that is inside the hernia cavity has been reduced. If you have any difficulty in reducing the hernia content, you can always open up the hernia ring. So you can see the video in which you must handle, you use always a bowel forceps. You can see these are traumatic. You can see a huge cavity of a huge defect. You can use a combination of scissors and a combination of advanced energy, like in this case, to reduce the content of the abdomen. I always suggest and teach my junior that it's always good to go in the preperitoneal space if it's necessary, and avoid to do, you can see in this case how I open the ring using a hook to facilitate the release of the content. So as I say, it's better to leave the peritoneum of the bowel and not the bowel on the peritoneum. Why? You can go on the preperitoneal plane easily and avoid to injury the bowel. This is one of the tricks to avoid enterotomy. So this case is a multiple recurrent. You need to be very cautious. Use your 30 degree to look around. and to reduce all the abdomen. You cannot limit to only one part because the hernia that you see is there, because there may be some occult hernia somewhere. So use always out traumatic instrument and avoid to traction too much. I think this is the most important. When you counsel the patient, remember that tell him that the risk of enterotomy in ventral hernia is about 1.6, 1.7%. So always less than 2%. Don't tell the patient that is uneventful. Even a primary single hernia carries some risk. So 1.5 to 2% is a risk of enterotomy in ventral hernia, laparoscopic ventral hernia. Examine all the abdomen, because you can see, like in this case, you can have plenty of defect along the midline, not only one. Measure the abdomen, reduce the intra-abdominal pressure. Usually we reduce by 10 to reduce the over distension of the abdomen. And after that, you can choose your mesh and choose your way to proceed. Why? Because if the hernia defect is so big, like in this case, you may think to close the defect. In fact, it's still controversial. There are still people think that no closing is no good, but you will see how closing the defect will reduce your seroma rate, your recurrence, your bulging. This is a patient of my first experience with large hernia in which the mesh is still in the abdomen, but it's all go inside the hernia cavity. So you have this called pseudo recurrence because of the big hernia. Why? Because bridging only it give you a weakness point. So when you do augmentation by closing the defect, you not only close the abdomen, reconstitute the linea alba, the midline, but also give the mesh a better support, being on the posterior wall compared to a simple bridging defect. So you can close the defect with the transfascial suture, like in this case. We always use a V-lock, in my experience, 30 millimeter, strong. You can use a 15 or 30 centimeter, and we can use a transfascial suture, like in this case, suture that allow us to close down and to approximate the defect. Usually the edge of the hernia quite strong and give you a good support. It's always a good precaution to when you tie the knot or when you suture to reduce the abdomen. In this way, you have more room for closure. If you work with the abdomen at 14 and 15 and try to close even 5 millimeter defect, it may be very difficult. But if you reduce the intra-abdominal pressure, it may facilitate the closure. Why we need to close? Because IPOM plus with the level of evidence of 2A is superior to the classical IPOM. We are talking about hernia that are bigger than 5, 6 centimeters. If the hernia is 2, 3 centimeters, maybe you don't need it. Reduce seroma, reduce the recurrence rate, reduce the bulging. So improve the cosmetic. What is in terms of mesh? I think Alan was talking about a mesh evolution. Today, the mesh are different technology that what we have even 10 years ago. And all the studies that we have today are reflected back 10 years. So the data that we have are not corresponding with the technology that we have today. So today, there are evidence and we have study and guidelines that show that mesh should have a pore size of between 2 to 3 millimeters. Let's say that correspond to a lightweight mesh because we have less biomaterial. You cannot call lightweight, but today we prefer to call large pore mesh that are still strong, but with less biomaterial. So we have evidence that the best mesh today are mesh with between 1.5, 2.5 millimeter pore size. We have, for IPOM, we have more than 100 meshes with different technology. They use a different type of film coating to protect the abdomen for adhesion. And we can see here a list of number. We mostly prefer either polypropylene and polyester compared to PTFE because PTFE create a capsule and create more seroma rate because it's a macroporous. So we prefer either polyester muli or single filament and polypropylene monofilament coated with different kind of technology. They all work well. Patient react different to each mesh. We can see in the post-op ileus in some patient no, probably because the mesh is always a foreign body, so we react differently. Where to put the mesh inside in IPOM? We need to overlap at least 5 centimeters. If the patient is obese, you need to overlap even more because you want to spread the intra-abdominal pressure to a large surface and closing the defect. So overlap the mesh with the lower pressure. Do we need to fix the mesh? Yes. We are not talking about inguinal hernia here. Ventral hernia is a different problem because we have abdominal cavity and we need to reconstitute the midline. So there is no tension-free repair in ventral hernia. And we need to close in a way that we secure the mesh with either fixation or suture. What is the best? Actually, all the studies show that there is no superiority of fixing the mesh with suture and with stapler towards stapler alone or towards suture alone. So you can choose which one is more comfortable to you. Probably in obese patient, you need to use both. Probably in small hernia, I use only tacker. In large hernia, I use both. That is my philosophy, but we have no data for that. And today, we mostly, for all hernia, we do IPOM Plus. We use absorbable suture. We have a wonderful tacker that are curved, allow a very good positioning. Stapler must be put at a distance of 3 to 5 millimeters with a bit of overlapping in between, the so-called double crown. What to do in hernia that are on the flank, on suprapubic, or subcostal? This will require a different kind of expertise. Probably they require another lecture. But overall, you need to follow the same principle of overlapping. And in case of suprapubic, you need to fix to the bone. It means to the Cooper ligament, like we do a TAPP. For subcostal, using the same. Please remember that the pericardium is there, so avoid damage and be sure. For flank hernia, you need to mobilize probably the colon, either right or left, and with the same position, or you go in an extraperitoneal way. So they require a little bit different approach from the classical IPOM. We have a good protection from our omentum, and we should cover at the end of the procedure, after the position of the mesh, make a layer of protection between the mesh and the intestine. I show you, for example, other way than IPOM, but I think Alan will show you later. You can do a flap, you can do a tap, you can go in the preperitoneal space, and then you can put any pro grip, any normal mesh that is not coated, or you can go directly. For example, this is a case of suprapubic hernia, in which we do, for a previous TAPSO, so we do a flap like a TAPP, and we prepare the preperitoneal space up to the pubis bone, and because this will allow you to fix the mesh to the Cooper ligament on both sides. You can see you go in a scar region because the patient have a TAPSO. So you prepare all the preperitoneal space, mostly for a mesh protection. You can go directly preperitoneal if you don't feel comfortable, like a ETP. You can just go behind the muscle and do a proper repair. So we have different approaches in evolution today. You can do robotic for lateral hernia. So like in this case, and usually we reproduce what we do in a proper abdomen. So you use a robot that facilitates your closure, but you do practically a TAPP approach. Like in this case, create a flap closing the abdomen and you move on. So the world is changing, but the complications are still the same. What? Usually pain is one of the complications, especially in the past when we use a titanium stapler. Today, I must say, I can discharge the patient the day after the surgery. Before, I need to, with the titanium tack, the patient stay in the hospital 3 days, 2 to 3 days. So this is the main advantage also of technology that evolved. The technique is still the same. When you do suturing, when you do transfascial suture, you don't need to tie too much, just lose it. You need to just hanging the mesh, not too tight to the abdomen. It's not, you need to fix the mesh. You just want to lift the mesh up. How to treat the patient? You can try with the nerve block, both lumbar block, transversus abdominal block, post-op, but only when the pain lasts more than 3 to 4 months. Seroma is very common, especially if you don't close, but even if you close, my seroma rate is about 8 to 10%. Asymptomatic seroma is about 70 to 80%. Symptomatic seroma, you can see like in this picture, the mesh and the collection on top. So depends on the patient. It doesn't depend most of the technique because even we close, we still have some kind of seroma. How to treat? Usually the seroma starts after 10 days, 7 to 10 days after the surgery. So drain is no use and usually disappear after 4 to 6 weeks. How to treat? Actually, you don't need to treat. Just treat conservatively. Only symptomatic seroma after 4 weeks, so means after you have a new peritoneum, you can aspirate under sterile condition. May recur in 20–30% of the cases. I was talking about ileus post-op. Extensive adhesiolysis are bowel manipulation, actually, are one of the causes. Large prosthesis too. PTFE also, in my experience, create more ileus than compared to other mesh. What you need to do? Nothing, just wait. Ask the patient to drink. If you like chewing gum, you can start to chewing gum. Enterotomy is a big issue. When you have an enterotomy because of adhesiolysis, just repair soon. Don't leave there and then go back because it's very difficult to find, especially if you have a serosal tear. If you want to have a good outcome, if you do an enterotomy because complication happen, we are surgeon, just treat it immediately. Don't wait. And if you have a patient that in the post-op don't doing well, have a bit of fever, a bit of tachycardia, is no same outcome as other patients, do a CT scan because it will save your night, it will save your worry, and so on. Consider the enterotomy may happen for different reasons, for adhesiolysis, for excessive use of a diathermy, or sometimes because the patient are undernourished, dysprotidemic, and so on. Infection of the mesh in laparoscopic are quite low compared to open. You can see 1% compared to 9 to 10% of open. Why? Because the mesh get infected by most of the time by Staphylococcus aureus, Streptococcus aureus, that are skin bacteria. So use a non-touch technique. So your mesh from the box that is sterile go directly inside the cavity. Doesn't go on. Don't put the mesh on the skin to measure if the mesh cover well your defect. Just use a piece of paper. And some of the companies, they give you a coverage that you can trim and measure. So no touch technique. Your mesh from the box sterile goes inside the abdomen. Cellulitis, this I think everybody knows, in surgery may happen because wound can infect 1 to 2%. What is the postoperative care? I think we use a binder in most of the patient. Before we use this bandage for 4 or 5 days. Now inside the operating room, we already put the abdominal binder to the patient because we avoid trauma to the skin using this bandage, compressive bandage. So we keep it for 4 to 6 weeks. We mobilize the patient soon, and we ask the patient to exercise after 2 weeks, light exercise, and then maybe strenuous exercise after 4 to 6 weeks. Good, strong muscle are a good protection for the abdomen. It doesn't protect from recurrence, keeping the patient in a bed for 3 months because the muscle get more weak and less holding. So what is the take-home message? This is written by Anil. I like it very much. So select your patient. Do a CT scan only in patient with recurrence of BIS. Use a safer access to the abdomen. Can be varus, can be open. Use a varus in the palmar point, usually in multiple operated patient. Be careful and just think always that the bowel is behind the omentum and the fat behind this adhesion that you're removing. In this way, you can avoid damage. Avoid use mesh that are coated. If you have an enterotomy with spillage, avoid to put a mesh. Do a 2-stage procedure. Overlap the mesh very well, at least 4 centimeters all around the hernia. These are probably the key for a successful and realistic outcome. Thank you very much.
Thank you very much, Davide. I have one comment on the CT scan. Yes, we do a CT scan if the patient doesn't do well after ventral hernia repair, but I'm very much in favor of rescoping those patients at the earliest. We learned this from the bariatric surgery, that if there is anything wrong, mesh infection, leak, bowel injury, whatsoever, you might even miss it in the CT scan. So I'm very much in favor of rescoping patients if anything is wrong and is not explicable by any other disease, let's say pneumonia or urinary bladder infection or whatsoever. So if you feel the belly is not fine, put the scope again. It's easy in the first 48 hours.
Yeah, we have no experience actually because we mostly believe in physical examination. I don't believe in CT scan. I reoperate patient with the CT scan negative, but the abdomen was
full.
Was dubbed. So I say I do the surgery, but the CT scan is negative. I don't care.
That's why I'm saying better to
so
look.
I think better say sorry than be sorry. So I think physical examination and patient is still the key. CT scan will help you. I don't have experience with colonoscopy, but maybe a good chance if it's negative.
Yeah. Now we can also go back to this question pending from the last presentation on mesh infection. You have already commented on the infected mesh. So when do you think a mesh has to be removed? When is the time to decide I have to remove the mesh?
Okay, if there are I never seen a mesh that has been salvaged if he got infected. I don't have much experience. I have maybe 1,300, 400 ventral hernia. And in terms of mesh infection for ventral hernia, I recall I have 3 or 4 patients coming from overseas, and not local. Most of the time, maybe was one of the questions you were discussing before. Mesh expired was used in one patient, I remember, and wrong technique. I think when you can try, with the culture, antibiotic therapy. But if they, after 2-3 months, patient is not well, I think you need to remove. In my opinion, for ventral hernia, you need to go earlier. If there is a sign of floating, a CT scan, ultrasound, you need to go in and remove it. There is no way to salvage a mesh. For inguinal hernia is a bit different. You can try, but usually very difficult to salvage a mesh infected, even in ventral hernia open. In laparoscopic, no, it's like a ventral IPOM. You need to remove. For open, you can still try, but it's very difficult to salvage a mesh in an infected mesh.
I agree.
The
So
chance
there's
are
one more question to you on the simultaneous presence of a hernia and a diastasis recti. So did you see a midline recurrence due to this divarication?
Oh, yes, we do quite a lot, quite a number of cases. Today, we only do if there is a concomitant hernia. We don't do as a primary treatment for diastasis because we are not plastic surgeon and because we work in an institution. So if we do a diastasis, we do a posterior repair. We do a posterior repair with the intracorporeal suture. Sometimes, if it's very wide, we use also transfascial suture that because they can facilitate the approximation. We don't have data. There are controversial, is anterior or posterior is better. The future will give us the answer.
Yeah, there was one question which just disappeared. Vincent was asking if there's an enterotomy which you missed during surgery and you go in again, would you remove the mesh?
Depends of the, okay, in that case, I have 2 patients, more than, actually up to more than 2005, 2006, in which we have an enterotomy, and the enterotomy, we were lucky, was going outside the abdomen through one of the port, the infection. So we didn't remove, in both cases, I never removed. Another case was because during the closure of the port, they entrapped the intestine. So we got enterotomy after 10 days. So if depends on the situation, if it's like this situation in which your infection and bowel content goes outside the abdominal cavity in the extraperitoneal space, you don't need to remove. If it's inside the abdomen, you need to remove. Especially because most of the time you do a stoma, you seldom do a primary closure because sometimes the situation is not so critical. So depends on the patient.
Anil, any comment on that? You are raising your hand.
Yeah, just 1 or 2 comments on this, Rolf. Like David said, David was lucky because his contents, you know,
He's always lucky. He's a lucky man.
Were not, you know, did not get it within the peritoneal cavity. But what normally happens in this sort of a situation where there is a missed enterotomy is that the setting is that of generalized peritonitis, because you have peritoneal contents that have spilled, you know, onto the peritoneal cavity. There is generalized peritonitis, and with that sort of a scenario, obviously the mesh would need to be removed at the same time as the peritoneal lavage and the cleaning and the closure of the enterotomy. So with all of that, you will find the mesh would need to be removed as well.
I agree with you, especially because the contamination is with quite a huge number of different bacteria. It's not the one Staphylococcus aureus or epidermidis. It is actually everything what the gut has to offer. So it's very difficult to treat. Yeah. Any other comments, Maki?
No comments.
I agree. Rolf, just a comment on infection on after a laparoscopic approach for ventral hernia. We've had some patients, actually we reported on this one. You can actually salvage some patients, some subsets of patients. We had this patient where we did a stopper-Reeves, laparoscopic stopper-Reeves retrorectus placement of a mesh. But then again, after a few days, there's an erosion of that thinned out skin layer. But then again, we did a CT scan on the patient where the rest of the mesh, aside from the area where it's excoriated, the skin was excoriated, there was a incorporation of the mesh already on the body. So it would always be dependent on the situation of the patient. So that's where the CT scan would actually do a big help in trying to assess that mesh. So if you have a CT scan and you look on the CT scan, you have a floating mesh, I think that's the time that you really need to take out that mesh out and then do your flushing, do your lavage. But for a CT scan result of where your mesh is already incorporated and fixed in the tissue of the patient, then I think a lavage or a debridement of that area would suffice in these patients.
Okay, Alan, you will be talking about the newer techniques in your next lecture. Do we have a poll for this?
Can we put the poll now, Alex? Can we post the poll? So the first question of the poll, number one, component separation technique may be used for hernia for a diameter of 4 to 8 centimeters. The second question is, robotic abdominal wall repair techniques have a great future. So let's answer the questions. Let's post the answer. For number one, component separation technique may be used for hernia of diameter 48 centimeters. 88% said yes, quite interesting. Robotic abdominal wall repair technique have a great future. Again, 96% said yes. So let's see.
96%. So surgeons believe in technology, obviously.
Yeah. I think the most interesting part of the poll would be the first question. Component separation technique may be used for hernia of a diameter from 4 to 8 centimeters. I think it's quite interesting. Let's see the answer to this one. Can we put the lecture now? Can we see the lecture? Can you see the lecture now? Okay.
Yeah, before you start your lecture, Alan, can I just say, do you want to comment on the first polling, the first question in the poll about the use of component separation techniques for moderate and smaller sized hernias? Do you want to say something about that?
I think it will be answered later by the lecturer, Anil. Let's take that question. We keep that in mind. And then after the lecture, let's talk about it rather than, what do you think? If you're okay with it. I think the lecturer can answer the first question.
Yes, I think you go ahead, Alan.
Yeah, okay. And then we can talk about it.
Yeah, yes, please.
Okay. Anyway, my lecture is about newer abdominal wall hernia repair. I think the field of hernia surgery is one of the most interesting field of in the field of surgery right now. There's a lot of interest, especially in abdominal wall, the anterior abdominal wall repair for ventral hernia. Inguinal hernia treatment has stayed, uh, almost the same from open, Liechtenstein, TEP, TEPP. It has always been the same. But for anterior abdominal wall, for ventral hernia, there's a lot of interest now, owing to the fact that there's a lot of uh, procedures that are being introduced. From the start, the outline of my presentation would be from IPOM, historically from IPOM, your peritoneal repair, and what we have right now uh, out in the field. So anyway, the interest is actually basically uh, from the concerns of IPOM since in 1993, when Carl LeBlanc from the United States introduced his first laparoscopic, he calls it intraperitoneal only mesh repair. So the concerns of doing an IPOM on this patient actually is centered more on, it's not really a repair, but a bridge repair. We don't actually repair the defect. If the edges of your hernia defect is this one, you just cover it up. So we call it a bridge repair. And the biggest issue would be a placement of a foreign body intra-abdominally. So an intraperitoneal, the presence of an intraperitoneal mesh in this patient. So right now, you have a whole gamut of, how do you call it, a alphabet soup of all the procedures that we have right now from IPOM, ITAP, EMILOS, SCOLA, LARDA. We have a lot of names on different procedures. Basically, if you look on, I would always want to show this video, this picture. The reason for this picture would be uh, procedures would always be dependent on if it's open, endoscopic, or laparoscopic. Open, we all know open, we incise a small incision of the skin and go to where you would want to put that mesh on. Endoscopic, if you'd want to use a small telescope to go in between the layers of the muscle, and laparoscopic, if you do want to go into intra-abdominally. And placement of the mesh would really depend on the name. So if you put the mesh on top of it, can we put this on? Go back, okay. If you put the mesh on top of your rectus muscle, of your anterior rectus sheath, then we call it your onlay mesh. If the mesh is in between the defect, we call it your inlay. And now I think the holy grail is your retromuscular. If the mesh is placed just beneath your muscle, your rectus muscle, we call it the retromuscular. And if you open up your preperitoneal hernia, then we call it your preperitoneal placement of the mesh. And of course, your IPOM or your intraperitoneal placement. We call it now intraperitoneal, and we do away with the only mesh on calling IPOMs, primarily because of it's a mix-up of your onlay and your intraperitoneal. So we just call it intraperitoneal. So basically, if you look on how we do our peritoneal hernia repair, so you open up a flap, you go transabdominally, you open up the flap, so reduce first all the hernia defect, bring down everything. So once you bring out all that incarcerated omentum or even your intestines, you do now a flap on your peritoneal area. Placement sometimes of a anesthesia or even saline can actually help in creating that peritoneal space. So we all know that when you go laterally, that peritoneum becomes a little bit thinner and more difficult to dissect. And sometimes you end up with a lot of holes in that peritoneal, on your peritoneum. So you don't want that. So just to help out in creation of that space, you can instill some anesthesia or even your saline just to make that space. So you do your dissection now. Once you've done your dissection, again, you bring down the sac. Once you bring everything down, you create now a huge space, a pocket of space where you can insert now that mesh, the mesh in between your peritoneum and your posterior rectus sheath. So this is how we do it. So placement now, you can either do a tucker or suturing, a transversal suture, or even just suturing that mesh on the posterior rectus wall. So we cover up always with the peritoneum, primarily because of we would want to protect the mesh. Unless if you're using a protected mesh, then you can do away with the suturing. So looking on the space right now, what we're looking at, if you look on the retrorectus space, this is now the new playground of all the surgeons that are interested in hernia repair. So we're looking on the retrorectus space as the holy grail of all hernia repairs for ventral hernia. If you look on the principles of a retrorectus placement of a mesh, it's actually not new. If you look on the papers of Stopa and Reeves during that time, looking on your GPRVS or your giant prosthetic placement of a mesh to reinforce that visceral sub, it's actually this one. It's the same. So you look on your ETEP space, the just behind your rectus muscle would be the placement of that mesh. So again, I would like to bring you back again to the layers of that abdominal wall. Let me go back. So the layers of that abdominal wall is important, primarily because of placement. Where you place that mesh would be dependent now on how you would name the procedure. So for retrorectus approach, you can approach it in three ways, either by open method. So that's where your name emailers can be, or will be placed. You do a small incision either on top of that hernia or that just below the hernia sac. Then you create a space going down to your rectus muscle. You can approach it endoscopically or your ETEP. So you go down in between your rectus muscle. You open up that anterior rectus sheath. From the anterior rectus sheath, you identify your rectus muscle. Then just below your rectus muscle, without traversing your posterior rectus sheath, you'll be able to go in between your rectus space. So we call it the ETEP approach. And you can approach it laparoscopically by doing a trans-abdominal approach. You insert your trocar on the side, then do your dissection from your peritoneal space and then opening up your posterior rectus sheath, going underneath again the belly of your rectus muscle. So regardless of how you would do it, you can approach it if you would want to add another procedure, which is a TAR. This is now your transverse abdominis muscle release, or your TAR. It can always be approached either by an endoscopic approach, laparoscopic approach, or even a hybrid or an open approach doing your EMI So just to move on, so just to show you how we do our ETEP, so incision can be done. So from here, at the anterior belly of your rectus muscle. So identifying your anterior rectus sheath, you open up your anterior rectus sheath, you go behind now of your rectus muscle, in between the posterior belly of your rectus muscle and the anterior part of your posterior rectus sheath would be the space that you would want to be into. So you go down, you dissect now, you identify now your rectus abdominis muscle on top at the ceiling, your linea alba at the midline, and your posterior rectus sheath at the bottom. So appreciation of this one is easy. Actually, this is now your posterior rectus sheath, the rectus muscle, and at the midline would be your linea alba. You dissect going down, identifying your inferior epigastric vessel. That's the one on top. That's your inferior epigastric vessel. And identifying the space of Ritzus. Likewise, you can do your ETEP again on the contralateral side. So again, the same procedure is done. So identifying now the anterior belly, the posterior belly of your rectus muscle, and of course your posterior, the rectus abdominis muscle. So you open up the aponeurosis of your rectus muscle in trying to crossing over. It's crossing over towards the contralateral side. So this is now your linea alba. If you have a diastasis, the diastasis can be seen here at this area. So that's the crossing over now. You can see now the posterior belly of the rectus muscle on the contralateral side now. So you open up the aponeurosis of your rectus muscle. Opening it up would now connect the right side to the left side. So a good appreciation of anatomy is really important, when you're doing your advanced surgery, abdominal surgery. A good understanding of that anterior abdominal wall anatomy. So now you're crossing over, trying to bring it down. This is now where we're bringing you up now at the area of that umbilicus. So you reduce everything that's herniated at that umbilical part. You bring it down. Okay. It doesn't really matter if you have a huge hernia defect on this side. You'll be able to identify right away the defect. So it's quite easy to do it. So now you're able to identify now the linea alba. So approximation of the linea alba or your defect is done using your barbed wire or your barbed suture. We use usually V-lock. And then you close now your posterior rectus sheath. This is not the posterior rectus sheath. Why? Because you will place now your hernia or your mesh on top of that posterior rectus sheath. So basically, you're following now the principles of stopper ribs, your GPRVS or your giant prosthetic reinforcement of your visceral sac. So placement can be done either using a transfascial suture. You don't use tucker if you want to do your tucking on the side. You can do your tucker on top. You don't do your tucker on the posterior rectus sheath. So just to move on, there's a lot of minimally invasive laparoscopic and robotic options for your extraperitoneal mesh repair for your ventral hernia. Ongoing evaluation and regarding long-term outcomes, we all know especially for TAR and your stopper ribs approach, the results are not yet there. We only have about 5 years outcome on this patient, clinical outcome on this patient. So operative time and cost, clinical benefit are still needed just to have a good outcome on this procedure. But we just have to remind you that newer techniques, it's quite easy to do, but then you need adequate training, especially if you want to go into your TAR or your component separation techniques. So just to move on, if you're talking about component separation technique, there are several anatomical approximation on how to do it. So you have two types. You have your posterior, your anterior component separation technique. So just to show you your component separation, there's a wide coverage of your mesh to reduce your recurrences or your GPRVS. We call it the giant prosthesis, placement of a giant prosthesis to reinforce that visceral sac. Okay, so for component separation technique, you have two types, your anterior and your posterior. You can do it either by laparoscopic approach or by open approach. So your component separation, you can obtain a huge fascial closure in large midline hernia. And that's a grade B recommendation. And component separation technique can be used with combination with mesh reinforcement whenever possible. And in cases of contaminated field, you can make use of a component separation technique with if you're thinking of not using a mesh for the closure of these defects. So for anterior component separation, we all know that anterior component separation has been around for more than 20, 30 years, popularized by Professor Ramirez. He's a plastic surgeon trying to approximate that defect in the midline. The idea would always be a reapproximation of that midline hernia defect. So it's a closure of a large midline hernia, at least 10 centimeters defect. If you're thinking of doing your anterior component separation, it's better actually to use your endoscopic or minimally invasive anterior component separation, because if you compare it with your open component separation, evidence would show you that the minimally invasive approach or the laparoscopic approach would be better for your patient because it reduces the postoperative wound complication or your wound morbidity by at least more than 50%. So you have a better wound healing in patients undergoing your endoscopic or minimally invasive approach. For posterior component separation technique, this is now the, how we call it, the new kid in town, the new kid of the block. There's a lot of interest in the transverse abdominal muscle release. This was popularized by Professor Yuri Nowitzki from the United States about 7 years ago. Transverse abdominal muscle release can actually be applied for abdominal wall reconstruction. So if you look on where we would usually do it, it's for M1, so it's a midline hernia defect, M1 to 5 with W3. So W3 is 10 centimeters or more. So to answer the first question on the poll, we only use component separation techniques for hernia defects that are quite large or with a huge, with loss of domain. So 10 centimeters or more, we can go for your posterior component or anterior component separation technique. TAR, or your transverse abdominal muscle release, can be used for recurrent hernia following previous anterior component separation. So there's always a question of, after an anterior component separation on our patient, can we do a posterior component after if you have a recurrence? The answer is yes. If for the question, can we do a simultaneous anterior component and the posterior component separation? The answer is no. Why? Because you'll be opening up a lot of defects on your patient, and probably you'll end up with a patient with a very lax abdominal wall and with a bigger problem later on for our patients. So for TAR, it can also be used for lateral wall hernia, like the one that David had shown you earlier, the robotic approach for a lumbar hernia. So TAR can be used for a large hernia, lateral wall hernia, from L1 to L4, grade C recommendation. For different adjunct techniques like your botulinum toxin, even though there's a lot of promises, a very promising result using your botulinum toxin A on this patient with the idea, the principle of a flaccid, making that the abdominal wall muscles flaccid, thereby repairing it with no tension, is quite promising. This was brought about by the studies of Hurtado in Ibarra Hurtado in Mexico. So how to do it? We'd usually do it under ultrasound. So this is the ultrasound view of your abdominal wall. So you can see now the layers, your external oblique muscle, internal oblique, and your transverse abdominis muscle. So we would usually do it under sterile conditions. So you can actually identify the layers of your muscle, external oblique, internal, and your transverse muscle. So we usually instill 300 mils or 300 milligrams per 1 ml of the botulinum toxin A on our patients. So the results are quite promising, but we still need a lot of papers to come out. This is what we call the chemical component separation technique. For robotic surgery, there's a lot of interest now in robotic surgery. And we've seen a lot of surgeons, primarily in the United States, doing robotic IPOM. It can be considered the results are comparable to standard laparoscopic ventral hernia repair, but the follow-up is still insufficient and adequately compared the risk of hernia recurrence. It also improves the ability of the surgeon to close the hernia defect, primarily because of your suturing actually at the ceiling. So it's quite difficult to suture an inverted suture on patients. But for surgeons who are adept in doing laparoscopic suturing, you'll see the usage of robotic is, I think, an overkill when you're doing your robotic IPOM. But then again, because of the interest in doing robotic surgery, we need to show you how a robotic surgery is being done. So robotic TPP has been shown to be safe and effective alternative to robotic IPOM or your standard intraperitoneal placement of a mesh in laparoscopic ventral hernia repair. Significant reduction in the length of stay of patients in the hospital is possible with robotic ventral hernia repair, but the recurrence rate is the same with open and laparoscopic ventral hernia. So, however, the long-term follow-up is still lacking, and we still need a lot of evidences showing robotic surgery is okay on our patient. But then again, the biggest setback or the biggest question on the usage of robotic surgery is the cost calculation. Quite complex. There's a lot of surgeons, especially from the United States, who would espouse on the usage of robotic surgery in ventral hernia, especially if you're using it just for IPOM or for your intraperitoneal only placement of the mesh, or even for robotic KPP. Primarily because of the cost effectiveness, especially if you're looking on the cost of robotic usage of robotic surgery in the Philippines, where you would add at least $10,000 US dollars to the whole surgery of your patient. But even having said that, further studies still needed to understand the cost of robotic ventral hernia in various forms. But I think the biggest advantage in the usage of robotic surgery is the ease of suturing or the ease of repair of that hernia defect in your patient. So I think that's the end of my lecture. It's just an overview of what we have right now in the field of ventral hernia repair. If you have any questions, we'll be more than happy to answer you.
Thank you very much, Alan. Nice lecture. I agree with the empathetic and enthusiastic answers of our participants in terms of robotic surgery in the future. So definitely you won't buy a robot for repair of ventral hernia only. So that is an overkill, as you said. I agree with you. However, if you have a robot at hand, the robot is a fantastic tool to tackle those. And as you said correctly, the learning curve is actually, once you are used to the robot, the learning curve for suturing or for even performing a TAR is much shorter than in laparoscopic procedure. So for the young surgeons, there is hope that they might be doing ventral hernia repair in the future with the help of a robot, given that the robot has to be available. And I also do think that the robots will become a little bit more cheaper. So since we have a robot, we do more and more our ventral hernias with robotic repair, and it's more fun. And you don't go home like a stiff monkey in the evening, because you sit comfortable in your console and can do the suturing without any major distortions of your back and of your shoulders. The shoulder pain will be perhaps transformed more into the hand, because if you operate for many hours, then the hands start to ache. Yeah. Any questions from the participants? I don't see any. Yeah, there are some coming up. Nice lecture, Alan. My query, most probably it should be, is should the classic component separation without mesh be performed?
Well, depending again on patients. Uh, for defects, mind you, we've been doing a lot of KR component, anterior component separation and comparing both of them. I would like to say, in our practice, we would classify our patients. For patients who are the hernia defect would approximate about 8 centimeters, 7 centimeters, but there's a difficult or just tension in primary repair of the defect, I would go for an anterior component separation technique. But for a medialization, for a huge hernia defect, like a 10 centimeters, uh, 10 centimeters defect, I would rather go for a posterior component separation. I do it on a or either on a APEP approach or a transabdominal approach. So I do my TAR on this patient. I would select placement of a mesh. I don't do a lot of mesh placement for anterior component separation. Although we've seen a lot of papers that would say you can place a mesh on anterior component, in our practice, we don't usually do placing mesh for anterior component.
Yeah, maybe to remind the participants, we are talking here about advanced new techniques. These techniques are mainly coming up for the last 2 to 3 years after a fantastic lecture of Maki yesterday and the nice lectures today. It seems that this is an easy thing to do. No, it's not. So basically, you have to start with your umbilical hernias and your inguinal hernias. They might be complicated enough in the beginning before you think about doing TARs and component separations in these different techniques. And eventually, with the help of robots, some time will pass by in terms of training experience.
Did we lose Roth?
Yeah, all this. So that will take quite some time. Furthermore, I just thought last night after the lecture of Maki about my my ventral hernias in my lifetime as a surgeon. So looking back over 40 years now, there was only one procedure besides the direct suturing 40 years ago, and this was the Mayo technique to tackle a ventral hernia. And that was already considered as something for the advanced surgeon at that point of time. If you look today at the list of possible repairs for a ventral hernia, it's just endless. Now, yesterday we discussed, or day before yesterday, we discussed how many techniques you need to master for an inguinal hernia. Now, I don't want to ask this question for the ventral hernia because it's just not answerable just right now. Any more questions?
The problem with doing a component separation, it's a different lecture altogether. Actually, it's a different, more than 2 days lecture of a workshop for doing your TAR, for the different, advanced abdominal wall repair techniques. So we just showed you an overview of what we have right now in the treatment of abdominal wall hernias.
Now, I think the difficult question will come with the next lecture from Anil, which procedure you will do for which case. But before going there, there was a very interesting question from one of the participants on the drains. Are you placing drains? What about component? What about TAR? When are you placing drains and what is the purpose?
Personally, for me, I don't put any drains on my patient. When I'm doing my ETPs or my rib stopa, even for my TARs, I don't put any drains. Even during the learning stage, going up. But mind you, I never went into the advanced procedure just on my own. I went out, I went to the United States, I went everywhere just to train before I tried it on my patients. I think it's incumbent upon us to teach ourselves first before we introduce newer techniques to our patient. So, but in my experience, I never put any drain on my patients for ventral hernia.
To stay in the Philippines, Maki, drain or no drain?
Well, Alan is doing it mostly endoscopic, so he can afford not to put in drains. I do it mostly open, so I put drains.
Okay, fair enough.
Raising his hand. Rolf,
Yeah.
I can see Anil raising his hand.
Yes, Anil will be the next speaker, so we will slightly drift into the next topic as there are no more questions. Yes, Anil.
Yeah, well, just coming back a little, Rolf and Alain, I was just a bit alarmed actually at the response that we got to our first polling question, and I've been waiting for an opportunity to let my views, come across.
Anil, can you come nearer the microphone? Your voice is quite muffled.
Okay, what I was saying was was a little bit alarmed at the response to the first poll question. So I thought I must make my views heard as well. Now about 90% of our participants thought, it is fine to do a component separation for a hernia between 4 and 8 centimeters. Now that rings plenty of alarm bells in my mind. Now, please try and understand that we talk about component separation techniques for the large hernias, like Alan said. For the large hernias, for the complex hernias, we talk about component separation techniques, just as a last resort. In fact, some surgeons call component separation techniques as a desperate measure for a desperate problem. So please keep it in mind. These are techniques that involve, damage to the normal anatomy, the normal abdominal wall. So these are techniques that have to be used very selectively, very carefully, and with a lot of training, obviously. So now I feel a little better once I've said all of that.
I agree with Anil. We stressed out actually the indication for doing component separation in our patients.
I mentioned it yesterday in my talk. The indications.
The thing with component separation is we always I don't do component separation technique just left and right on our patients. Number one, we have to think of we're destroying something. So it's not actually a repair. We destroy something in our patient. And the results of component separation, especially the posterior component separation, the results are yet quite young. And we haven't seen the whole picture, the bigger picture of what our complications will be a few years from now. So maybe after 10 years or 15 years of doing component separation, especially the results coming from the American group and the European group, would tell us if we are correct or if we're not in giving up this treatment to our patients. And I think we need to be a little bit, hold ourselves back in giving this treatment. So that's my, if I can do a stopper ribs endoscopic approach and I do primary repair, I'll do it without even thinking on, I'll do it right away on my patient. It's better actually. Placement of a mesh without disturbing anything, doing your primary repair anteriorly, suturing it anteriorly, and then just placement of a mesh, a huge mesh. I'd be very happy for my patient. But then again, some patients even with 8, 9, 10 centimeters, sometimes you cannot really close it. That's why we do a lot of our patients now giving botulinum toxin. Why we found out that for patients with 8, 9, 10 centimeter defect, we can actually repair that defect without any tension. So you can do away with just doing a stopper ribs placement. So I think it's one of those things that we need to look into. There's a question. Yes, sir.
On the same topic that has been discussed or presented yesterday, I think by Maki, you have not to forget that the transverse abdominis is part of the breathing system. So if you do a TAR, you might compromise breathing. And in many cases, and we have seen it also, patients might opt not to have any repair of a ventral hernia done because they don't have pain. It's more or less a cosmetic problem for many of them. So you don't want to end up in functional problems for a, I don't want to say cosmetic repair, but for a quite tolerable condition. So also you have to take into consideration, and I think we will come to this now with Anil's discussion, the age of the patient, the weight, whether there is or not loss of domain, etc. So before putting the patient at the risk eventually to die, you have to think twice and thrice. And therefore, component separation, TAR, loss of domain surgery, that is really, really something for the super experts.
Right. Can we move on then, please?
Okay, Anil, is there any poll for the last one, for the last presentation?
If you would agree, that there's one question in YouTube from Dr. Romel Salazar. How do you deal with tears in the peritoneum while doing your component separation? Who wants to answer? Maybe David? Is David still here?
You repair. You have to repair. Alan.
Yes.
I'm here.
You have to close it.
The question is, what do you do with your tear in the peritoneum when you're doing your component separation? So either you're doing it laparoscopically or open, you need to repair it. Why? Because if you don't repair it, you're exposing now that naked mesh. Because what we're using, the mesh that we're using is just the regular mesh. It's the unprotected mesh. So you want to repair that posterior layer, either the peritoneum or the posterior rectus sheath. You close it, and then you put your mesh.
I can add that not only the contact between the mesh, but also the small bowel can go through the hole in the preperitoneal space. So you want to have an intestinal obstruction post-op. Okay, great. Let's move on then.
There's a simple answer to it. Don't make holes in the peritoneum.
This is
Easier said than done.
the Murphy law. The Murphy law.
Yes. Okay, Anil, are you ready?
Yeah, can I share my screen now, please?
Yeah, now the very interesting questions. What you do when? Or if?
Yes. All right. So my slide is viewable.
Yeah,
Okay.
everything is on.
Can I be seen, as they say in the trade?
Yes, you can go ahead.
Okay, thanks, Rolf. So we will try and be a little quick here because we are running behind time. We will not talk about contraindications because David has talked about this earlier. Now, this is a patient scenario for you. You know, just like we had yesterday. This is a 30-year-old female with incisional hernia at the site of her previous cesarean section in the lower abdomen. Now she's got a hernia there, but she plans to have one more baby in time to come. And she wants to know from you what to do about the hernia that is there now. Okay? So she needs an opinion. Now, these are the surgical options. Obviously, for this patient, you can either say that we operate now, or you can tell her, complete your family, go ahead with the second pregnancy, and we then do it at that time. Or you can just tell her, let's just wait and watch and do nothing. So do we have polling for this, please? Oh, there we are. Cherry is on the ball. Good. Thank you, Cherry. So these are your options. What do we do for this patient? And can we have the polling, please? Okay, so most people believe that wait for the second pregnancy, let her complete her family, and then repair the hernia under controlled conditions. And that's what I also agree with. The message here is female patients of reproductive age who wish to have ventral hernia repair should be advised on the increased risk of recurrence when there is subsequent pregnancy. So it is much safer to wait, let the patient complete her family, and then go ahead. Now, the next patient scenario for you. This is a 65-year-old gentleman with a reducible para-umbilical hernia, 4 centimeters in diameter. Okay, he's a diabetic, he's an asthmatic, under reasonable control. Now, this chappie has come to you for an opinion for his hernia. Okay, these are the surgical options. Again, you can either tell him, come in, buddy, we will operate you, day after tomorrow, or go in for a period of medical optimization and then operate, or see again, wait and watch only, let's see what happens. So what do you recommend for this gentleman? Okay, can we have the polling, please? Right. So our chaps are on the ball. So most people believe medical optimization and then surgery for this sort of a hernia. And I completely agree again with our friends. So the message here is that small abdominal wall hernia defects may predict emergency repair, because these smaller hernia defects are more prone to problems with time. So it is recommended that symptomatic hernias should be treated surgically. Okay, the updated guidelines from last year. So watchful waiting for these sort of hernias is safe, but then there are high crossover rates, which means that more and more patients would need surgery with time. So watchful waiting is just suggested for medical optimization in patients with modifiable risk factors like diabetes, asthma, smoking, and stuff. Okay, now this is a slightly tricky one, and somebody, many people may have their eyebrows raised at this one, but here goes. 45-year-old female, BMI 28. Okay, small para-umbilical hernia, 1.5 centimeter defect. Symptomatic hernia. She's come to you for opinion. Doc, what do I do about this? Okay, symptomatic. So she has asked for surgery. You know, obviously something needs to be done. So now, between a sutured repair and a mesh repair, okay, can we have the polling here, please? There you go. So how many of you would do a primary sutured repair? And how many of you would do a mesh repair for this hernia? Or 61% again, mesh repair, and 39% primary sutured repair. And I agree with the majority again, because we have recommended, in fact, we have guidelines now from last year only, from the IEHS recommendations of last year, that have clearly stated that mesh reinforcement is suggested for even small umbilical or epigastric hernias to lower the risk of reoperation for recurrence. So here it's a slightly funny situation, because here you in fact trade off lesser recurrence for more morbidity with the use of a mesh. But you know, we have studies that in fact point to the fact that for these smaller umbilical hernias as well, one needs a mesh to reduce the medium and long-term recurrences. There you go. Slightly funny. Many people would not accept that, but that's how it is. Okay, let's just move on. So, well, David has talked about all of these steps of surgery during laparoscopic ventral hernia repair, starting with the initial intraperitoneal access, careful adhesiolysis, reduction of hernial sac contents, the entire ventral wall to be examined, followed by placement of a mesh, and finally the omental cover. Very important. Now you have got an incisional hernia that you are dealing with. Now what I'm asking you is, what is the extent of the adhesiolysis that you will perform? Would it be 3 centimeters around the hernial defect? Would it be 5 centimeters around the hernial defect? Or would you like to see the entire previous incision? So do we have polling for this? No, perhaps not. Perhaps not. So yes. So the entire previous incision obviously needs to be examined, because you can have segments of the previous scar that may be weak, which may form a nidus for a subsequent hernia, you know, that may come up in the future. So one of the advantages of laparoscopic surgery is that with the laparoscopic approach, you can see not just the site of the hernia, but you can see the entire previous incision, and for all practical purposes, the entire abdominal wall from inside. So you can put in a mesh accordingly. Okay, that is the advantage of the laparoscopic approach. Now, what do we have here? Okay, the slide is missing, but I'll tell you, this is a 50-year-old gentleman, okay, with incisional hernia. Okay, lots of small bowel adherent to the abdominal wall. you are performing adhesiolysis, but lo and behold, to your horror, you have made an iatrogenic enterotomy. So you have made a large hole in the small bowel. So what do we do now is the question. You were doing a laparoscopic incisional hernia repair, lots of small bowel adherent to the abdominal wall. You have made an iatrogenic enterotomy during adhesiolysis. So what now? So these are the surgical options available to us, practically speaking. You can just close the enterotomy and do nothing else. You can close the enterotomy and do a sutured repair of the hernia, or you can close the enterotomy and do a mesh repair of the hernia. So we have three options practically when we are in that sort of a situation. So what I'm asking you is, what would you do in that situation? Just close the enterotomy, do a sutured repair of the hernia, or close the enterotomy and use a mesh, do a mesh repair of the hernia. Okay, can we have the polling answers? There we go. Okay, I must say the participants have restored my faith to a large extent, because I'm getting all the right answers here, Rolf. They are a good bunch. So yes, most people would not put in a mesh, in this sort of a situation. Most people would just close the enterotomy and do a sutured repair of the hernia. And for me, that makes a lot of sense. Again, because the message is that, like we saw yesterday, for the setting of hernia, you must have a clean surgical field, because this involves the use of a prosthetic mesh. So well, whenever there is contamination, do not use a mesh. Okay? Defer the placement of a mesh. And this clip is just to show you, like David mentioned, some time ago, that as soon as you think you have made an enterotomy, suture it right there and then. Okay, that is the message. Do not wait. Do not think you will come back and look at that site, because most of the time you can't find out that site. It has been lost, been covered maybe with a blood clot, with some tissue debris maybe. So just suture, as soon as you think you have made an enterotomy. That is the message. Now here, just to, yeah, we have what, 15 minutes left, is it? No, we are almost done for time. So we will try and rush through. Now, this is a situation that we find, not so infrequently. So you can see that there are multiple loops of the small bowel that are going into the hernial sac. And you've been trying about 15, 20 minutes. You have tried just about everything that you could, but you still cannot reduce this small bowel from the hernial sac. So what do we do now? That is the question. What do we do now? Now there is no polling for this. So I will tell you. Oh, no, not this one. Sorry, Cherry, this one follows. Right. So you may remember that Dr. Chaube spoke about the hybrid repair. Okay, this is in fact one of the options. You have laparoscopic repair, you have open repair, and then you have something which is called the hybrid repair. So in this sort of a scenario, you can do the hybrid repair, which means make a small skin incision about 7, 8, 9 centimeters long on top of the hernial sac and perform the adhesive lysis under direct vision with conventional instruments. This increases the safety of your surgery. Okay, the small bowel loops that were part of the hernial sac can now be examined to make sure there has been no damage. If you find any areas where you think there may have been damage, you can always put in a suture. So that again makes your surgery safer. And finally, do an airtight closure and then put in an intraperitoneal mesh laparoscopically. So this is the hybrid approach for these sort of situations. Now we will just talk about perhaps one more scenario because we don't have time, and then we will call it a day and then go on to the MCQ. Right, so now you have this hernia 7 centimeters in diameter. Okay. Now this is what needs to be repaired. So well, obviously, first of all, you will try and close the hernial defect. The sort of IPOM technique, there is a bit of divarication also, as you can see. So close the hernial defect, close the divarication, but then what is the size of the mesh that you would use in this patient? That is what I want to ask. Now, to make things a little simpler for you, you have these sizes of meshes available with you, in the operation theater. So which mesh would you use? Can we have the results of the polling, please? Right. So just saying it again, 7 centimeter diameter. Now, most people would use a 15 into 15 centimeters. So that may be good for, I think, Kuya Allen and Kuya Maki, because this patient would then subsequently go to one of them for a subsequent repair for recurrence. Because this patient, a 7 centimeter diameter that has been repaired with a 15 into 15 centimeter mesh would recur within a year. This is the mesh, that needs to be used for all practical purposes, a 20 into 25 centimeters mesh. Now, formally, we used to talk about a 5 centimeter of mesh cover to try and decide what size of mesh to be used. So we used to talk in terms of a 5 centimeter overlap of the mesh in all directions. Now, that also, we have been told now is not correct, because like David also said, the larger the hernial defect, the more is the mesh overlap that is required. Please remember. And now we have some suggestions, in fact, to tell us that the mesh area to the hernia area defect ratio should be 16:1, which means that the radius of the mesh that is used should be at least 4 times the radius of the defect. So just think about it. 4 centimeter diameter defect, which means 2 centimeters radius, would need a mesh that is 4 times the radius. So 2 centimeters is radius of the hernial defect. So you in fact need a mesh that is 4 times that radius, which means you in fact need a mesh that is 8 centimeters in diameter. That means you in fact need a mesh that is 16 into 16 centimeters for a 4 centimeter hernial defect. Okay, that is what this means. But then basically, just try and keep it simple. As the defect size increases, the size of the mesh overlap should also increase. So well, practically speaking, for a 7 centimeter hernial defect, you need at least 7 centimeters of mesh cover on all sides. So that is why I said the mesh size should be at least 20 into 25 centimeters. Now, okay, I think we stop here for want of time. And what I have to say now is that that we will very shortly start the MCQ test for you. Now, what is first going to happen is that you will have a slide that tells you how to log in for the test. Okay, so once you have logged in, we will then give you 25 minutes for the test. There are 30 MCQs, and you have 25 minutes so that you can take the test. Now I'm trying to get to the slide that will take you to your login. Okay, so is that clear? Do we take a 5-minute break so that people can sort of get refreshed and come back for the MCQ, or should we just go ahead anyway? Do we have any suggestions?
Maybe take a break a bit.
Let's go ahead. Sorry?
2 minutes. Maybe take a 2-minute break.
Yeah, okay.
For them to stretch a bit, gather their wits for the exam.
2 minutes. Okay.
Take some deep breaths, stretch a bit, loosen up a bit, let the mind wander here and there, and then come back in 2-3 minutes, and we will then go ahead with the MCQ for you. यहाँ आ जाओ बिल्कुल। अच्छा, तो ये क्या
जो आप करेंगे ना तो वहाँ पे रिकॉर्ड भी करूँगा।
अब सिर्फ इसके ऊपर मैंने क्लिक करना है।
क्लिक करना है
ये स्लाइड के ऊपर।
हाँ, स्लाइड को क्लिक
And then we in fact wait for a while. करना नहीं है भाई।
नहीं, इसको ऐसे कर दीजिए तो नेक्स्ट आपका आ जाएगा और नेक्स्ट आ जाएगा। जैसे क्लिक करेंगे ना यहाँ से तो वाली स्लाइड खुल जाएगी।
तो फिर उसके बाद अपने को ठहरना है, कैसे पता लगेगा सारे आ गए?
वो तो बताइए ना, वो भी है, टीम भी है।
Okay. Do we have Keen around here? Is she there? Ate Keen.
This is
Hi, Prof. I'm here.
Ah, well done. So I'm not feeling lonely anymore with you around.
I've been here with you the whole time.
Oh, thank you. Right. So my next slide would be the login slide. So when I get the signal from Kuyamaki, then we will display the login slide and then perhaps wait for a minute or two so that they can all log in. And
Yeah,
then,
go ahead, Anil.
Okay, can we start? So, okay, well, this is the way that you log in. So you can either log in by using the QR code to the left, or you can log in by going to a www.pigeonhole.at and then enter the passcode, which is APHS1. So please do that now.
So those of you that have iPhone, all you have to do is open up your camera function and then just point it to the QR code and it'll take you directly to the site. But if you're using a non-iPhone, if you're using a laptop, for example, you have to enter the www.pigeonhole.at and then passcode APHS1.
Linda, can we see, if somebody has a problem with this, do we have a view of the participants so that in case somebody has a problem, they can raise their hand or something like that? Do we have a participant view here? No, I can't hear Linda.
Linda, you're on mute still.
Oh, I'm so sorry.
Oh my goodness. She was actually not with us. Can you believe it?
Try again.
So what I was asking was, do we have a participant view that we can see on the screen to make sure they've all logged in?
Cherry to be on the line. Ate.
Actually, I can see about 16 people that have logged in already.
Okay, well,
we're expecting 30 something, right?
Yeah, because without the MCQs, they will not move on.
Okay,
Can I start the clock now?
Yeah.
Okay, everyone, I hope you can log in because right now I can see about 18 participants that managed to get in already. I'm going to start the timer for 25 minutes starting right now.
No, let's please hold on, Keen. Let us have more participants back. Let us give them another 2 or 3 minutes so that they all come back so that we can have the same 25 minutes for all participants.
I think some of them already started. Oops.
How many participants now do we have, that have logged in?
18.
Right.
18 people have done the first question.
Oh, have done the first question already?
Yes.
So
it's okay, an extra 2 minutes.
Can we suggest that we give them 5 more minutes? If they don't log in, then we would not be able to be fair to the others that have started the exam, the MCQ. Is that okay?
Yeah.
Because I can see the names here and it was supposed to be a 5-minute break, but then if another 5 minutes from now, they don't come back, we will need to close the MCQ out.
Yeah, okay, so 5 minutes from now then, 5 minutes from
We
now.
will try to alert them on the WhatsApp message. Please, please go into the MCQ urgently. We'll do that now.
Yeah. Thanks, Linda.
Okay,
Right.
I'll do it right now.
So how many can? How many have logged
21. 21
Oh.
have done the first question.
Oh, okay. So just a few more.
Yep.
Oh, one message, I'm getting invalid email when entering.
There's no email.
There is no email. It is a www.pigeonhole.at. So if you go to Google Chrome or whatever, just type in www.pigeonhole.at, then it will prompt for a password.
Yeah, so in retrospect, giving a break was not a good idea. You tried to be too kind.
Always, Anil, as always.
I just sent in a message for those who can hear it. Can you please just let the rest of your dear doctors know that we will close the MCQ link in 5 minutes, which means that retest is not allowed. So just to be fair for those who have started logging in and doing the MCQ.
25 minutes, not 5.
I mean the link for those who are in. We will actually close off in 25 minutes, which means that if you don't have enough time, we will close it off.
Oh, we're
How
getting
many
there.
is
26.
there already?
26. Come on, guys.
26, great. Awesome. Any more, Kian?
Nope,
Still at
still
26?
going.
Okay. So Dr. Anil, maybe next time, toilet break after the MCQ.
No toilet break at all.
No toilet break.
Okay, I think I can start the 25 minutes.
Yes, please. Yeah, please do that. So you have
Okay.
25 minutes for 30 questions. You can start answering now, please.
Sorry for the interruption. Once you get to the question with a photo, what you can do is tap on the photo and it'll expand for you so you can have a bigger photo on your phone. All right, so once you're in the question 18, for example. Just tap on the photo.
अच्छा और क्या बोल रहे हैं? That's it? कोई उसके साथ तो मेल जाएगा ना? हाँ मेल के साथ ही होगा पार्टिसिपेंट्स के Linda, the next time I think we could have a timer or something on the slide that starts at 25 minutes so that
So you want to put a timer up here so that we will count down, right, Dr. Daniel? Got it. Noted. Noted.
thanks, Linda.
But we will let them know just 5 minutes before we close the link. Is that okay?
Okay.
Kian, on your time, Kian, 5 minutes before we close off the link.
Yeah, it's 19 minutes left.
Okay.
Anil,
Hi.
so what is the plan now?
The plan now is to wait for them to finish Davida, and then we thank everybody and then bid them goodbye and
Okay.
wait for the next session.
Okay. So no discussion, nothing much, right?
No, I think that's it. Thanks, David. If you have to move on, please do. Not to wait.
Okay.
Yeah.
Okay, then thank you. Thank you, Anil.
Okay. Thank you, Anil. Thank you, David.
Anil. Thank you. Thank
See you next time.
Okay, see you next time. Bye-bye.
Davide, I will call you later. Are you available in an hour or so?
Of course, I am very available.
Okay.
Every day, every time.
We are doing a lot of work.
Yeah.
Arlian,
Oh, yeah.
you know, 16 project Elsa is doing. 16.
16 project. Yeah.
Oh, from Indonesia, I keep and Donald helping.
Yeah, good.
So I try to. Do you have anybody else? We have a group of 22 people. Very good. Very active.
Very active. Yeah, good.
I tried. Anybody you want to involve for Indonesia?
Yeah, okay. Yeah. I have Dr. Haryanto. Is a very young surgeon.
Yeah, okay.
Yeah.
Okay. Ask him to email me. But young, don't give me 50 years old people like
No.
like Philippines. They give me 50 years old people. They cannot move.
Yes,
50 years young.
They say young.
Yeah, very good.
Yeah, I send. I ask him to send you the email.
Okay,
Yeah.
ask him to email. Yeah, perfect.
Yeah, this is a very aggressive man.
Wonderful. Yeah, I think we should do something.
Yeah, of course.
Okay, Balian, keep in touch.
Yeah, bye. Okay.
Bye, Rolf. Bye, Linda.
Bye, Rolf.
Bye. Bye. Talk to you later.
Bye.
Bye.
Okay. Bye. Call me. Bye.
Nobody is asking on the chat box how to answer the questions, Anil.
Well, we have spoken enough now, Rolf. It's time for them to speak. Oh, I'm so glad to see Ate Keen back. Very happy back.
How much longer do they have?
12 minutes.
Okay.
Oh, 12 minutes. Okay.
Have they all nearly completed? Do we know?
1 second. I think some of them are almost done.
Okay.
How many participants are taking this now?
26, right?
Yeah.
26.
Yeah, some were done already.
Is it possible to put the picture of the participants, of the 3 best participants on the screen, or is this not possible? No?
Names?
No.
Can you have their names?
I need to go offline and do the analysis to see who's the top.
We can promote them, right?
Yeah.
For the 3 top, we can promote them to panelists so we can see their face.
Okay.
Rolf, yeah, Anil.
Yeah. Good idea.
Okay, for those who want, if we have the answers now and then we get the results, anyone that you would want to put on video, we can promote it from our point.
So, Alan, what do we do if 5 people occupy the 3rd position?
That's your call. You're a rich man from the Middle East, from Dubai. You've got all the oil dollars with you, so you have to
the oil
decide.
price is down, Anil.
So you have to decide what to do.
Oh, we have to.
Well, we will see what will happen.
We have to get results from Ken, right, Ken? You'll inform.
I won't know what the scores are. Only the participants know until I go back and analyze it. For the participants, once you have submitted all your answers, you should be able to see your own score and then also the correct answers. Can you please take a screenshot of that page of your score?
You know what we can do, okay? After the exam, and then you send them the results and the result of their exam. You're right. Take a screenshot, and then send to the WhatsApp group. We made a WhatsApp group for them. All the participants together with Wang, Linda, right, Wang?
Yes, we do. We have their WhatsApp group.
We have
Yes,
that
sir.
group.
Yes, sir.
So send the picture of your results on that WhatsApp group. Then we'll be able to find out who has the highest exam, who garnered the highest score, and then we promise not to publish the lowest. Okay, so we'll inform you who are the highest. If we get 5, and then the 5 will be given a lifetime membership to APHS, courtesy of our president, Rolf Hart. Yay!
Obviously, I have no choice. No? Pressure from Anil, pressure from Ellen. Maki already left.
Someone who responded on our WhatsApp chat results already.
Yeah, one already sent.
Yep.
Okay.
I'm still here.
Okay, so.
No, hold on. The test is still not over. Completed the 25 minutes. We wait for the test to get over, and we then see who scored these are the highest.
Yeah, they're just sending in their test result. That's right. That's
all right.
They're coming in right now.
Okay.
7.5 minutes left.
Not bad. Very good score.
Nice score, huh?
Very good score.
Very nice.
Prof. Rolf, you may have a lot of eco marks if they are that good.
I feared this already. That was the reason for my question.
I took this exam, huh? I got only 2 correct answer.
So we got 225 so far.
Wow, 225.
Oh, it's 6:55. 2:20. 2:25 is this afternoon. It's already 6:55.
Oh, another one. Oh, yeah.
3:25s.
So we have 3 winners already. We can stop here.
One.
We have to stop.
Well, yeah, can't afford it.
I think the credit to all the speakers and the faculties, obviously. It is credit to the speakers and the faculties.
Yes, she knows how to say the right thing always. That is Linda for you.
Anyone else doing the exam? Kian, we can stop it?
Still 5 minutes. Yep, it's still coming in.
Okay.
They're still sending their results. So far, we have 3:25s.
Ate Che and Ate Wing, can you help to keep an eye as well?
You want me to take the eye?
No, sir.
Okay, 5 minutes.
We wonder what score you will have.
Okay, 5 minutes left is what I'm told. 5 minutes to go.
Yeah.
Hindi sulat ko lang. 28/30.
And Dr. Anil, once again, for those who have done the MCQ and those who need to have not passed the passing score, do they? And then about the certificate as well, we just need you to brief them as well.
Yeah, so when you in fact give me the chance, I will speak.
Good.
Kian, can you have a look at a attendee named Johan Bakilat?
What about it?
His score, because his screen closed off before he can take a print screen.
Oh.
Just WhatsApp me and I'll just put it in.
Yeah.
You can actually just type your score. I think you still remember your score, right? Johan Bagilat.
Yeah.
Got 30. Really? Wow.
Hey.
Well, we have to, Kian has a copy from her end.
Okay, so a disclaimer. Final final score will be issued after I look at the details.
Once you look at the final details.
Yes. So once everyone's done, I need to export it and then analyze it. And then the result, I will send it to you all.
Will we be able to analyze it in front of everyone here, or Kian will give you some time?
I need some time because it's not so easy.
Okay, so that means that we could only pick up those top scores first as of now, right?
Yeah. Yep.
Any more? Should we come to a close soon?
2 minutes.
do we have all the results?
You said 1 more minute.
Ilan sila? I think Kian has the final results.
Yeah.
When can we have it, Kian?
I can analyze it after this meeting and send it to you tonight. Or within the hour, maybe.
Okay, so what time's up, sorry?
Well, time's up.
24 seconds.
Just texted, who will announce 25 minutes over?
Okay, 10 seconds.
7 o'clock. It's 6:59.
5, 4, 3, 2, 1.
Okay.
Closed.
So please close the MCQs now officially. So well, thank you everybody for being part of this program. Thank you for your time. Thank you for your patience. We are still waiting for the results, and we will have final closing remarks from our president. But I wish to take this opportunity to thank so many of you who have worked so hard to see this training program come to a fruition. This particular edition of the training program was special because this was the first online training program that we had. And secondly, it was special because we had all presidents that spoke here on this training program. So you had the opportunity to draw from their wisdom and their experience with hernias. I'd like to first of all thank all our faculty that have spent so many hours being with us and training us. I'd like to thank PCAS, Kuya Allen, and Ate Cherry Lou, of course, Keen. They've been working behind the scenes for several weeks now to put this training program together. I want to thank Medtronic, Linda. Take a bow for Linda. This was her brainchild in a sense. She was the one who started, thinking about this, and so we in fact would be doing about 6 or 7 more programs like these in time to come. So I'll thank you, Linda, and thank you. Who else? Anybody else left? I'm sure Rolf is a much more alert professional than I am when it comes to these thank you speeches. So okay, before I forget, sorry, the most important part. We have already sent the participants a mail with the feedback forms. Now, please send the feedback forms back to us. It won't take much time, maybe about 2 or 3 minutes per form. So please complete the feedback forms, send them back to us. We take these forms very seriously because this is like a sort of an audit for us to keep slowly improving from one program to the next. So once we have received your feedback forms, we will then send you your certificate of participation in the course. So you can do that, at your earliest convenience. And I believe Pankaj has been working this morning to make sure certificates are in place. Rolf, Your turn now.
Yeah, my pleasure to thank everyone, and including Anil. He couldn't thank himself because he is the director of this program. So I will do it for you, Anil. Thank you very much for inventing this program and for being so persistent, because we had so many. Remind me, how many? That was the how many is the HE program we have done?
27.
27th, yeah. So it always has been my pleasure to be part of this program. So it was not difficult to accept the invitation to be here for the last 3 days. I hope you enjoyed the show, and there are, of course, for you a lot of important things here. Number one is you need to get your certificate, of course. Number two, as promised, the 3 best will get the live membership. And I think we know already who this will be. Is it right, Linda? So we will announce it, who will be eligible for this complimentary live membership. Number 3, and most importantly, I hope and I wish that you not only enjoyed the show, but also learned about hernia surgery, because as you can see, hernia surgery is one of the very old types of surgery done for almost hundreds, if not thousands of years now. But it is still developing and fast developing. And I liked to see your answers to the polls, which is always very interesting to see how the newcomers look at it. Not astonishing to me, your enthusiasm for the most complicated procedures and the most advanced procedures. I think that is a typical thing for people who learn to look at the most complicated things. However, the simple things are demanding enough. So you might have heard and seen in the videos that even so-called straightforward or simple hernias, even a normal inguinal hernia, can suddenly pose quite some problems. I saw one question which I didn't answer in talking, but in writing. What do I do if I suddenly injure the triangle of doom and I cause the bleeding? It's a catastrophe, of course. So, but it happens. I mean, it's not impossible that this will happen, in spite of all the warnings and the caution you will apply. So my wish for you is that you will have a very successful career in hernia surgery, that you will hopefully complete with us the second part and the third part. Anil has shown to you in the very beginning in his first slides, where are the centers of excellence. If you have any questions, if you have any doubts, just contact us or send us messages, either through the website or to us directly or via email. We don't mind. What is very important, if you don't give your feedback form, even if you are under the first 3, sorry, you will lose your membership. Okay, so with this, thank you very much for attending this course. It was a learning experience for us as well, because it was our first online webinar course. Courses normally are hands-on and we like to see the faces. Anil in the beginning also said, I cannot see the faces of the guys to have an estimate whether they're understood or not. Maybe we can improve this, that we put some of the faces on the screen so that we will have an idea what the people think.
Eileen?
But I think already it was a nice course, very successfully organized without hiccups. And yes, hope to see you soon. Last but not least, I will come back to the members and to you in the near few weeks from now, because as you know, our annual conference has been postponed to next year in Shanghai. It was supposed to be this year in China, and that will be now in 2021 due to this pandemic. But we will think about an alternative, and with those ideas after this successful webinar, we can come back to you and let you know whether we have another major event maybe in October or November this year. So thank you very much. And again, thank you to the entire team for the participation and for the sacrifice of your time and partially of your weekend. So back to the Philippines, have a nice dinner and a good evening. Bye. Bye-bye.
Thank you, Ralph. Do you want to promote everyone in the panelists so you can see all the faces of the participants? And then we'll call out the top 3 or top 4. Arlene, can you promote everyone, all the participants as inside the panelists so we can see the faces of the participants?
Alan, can we turn off screen sharing already for Anil?
Please turn off the screen sharing, Arlene.
Okay, all right, sorry.
Oh, somebody with full equipment.
Then we go.
Show your videos, please.
Arlene. Yeah, and then we put all the video, all the pictures of the participants. It has to be done one by one, so please bear with us. Anyway, just for the participants, please write down your suggestions, your comments after after this one, because this is the first online workshop that we've done. We really need your comments and your suggestions to make the next workshop online course a better one.
Thank you, sir, for everyone. It was a very informative lecture, and I really learned a lot. So thank you to all the speakers for giving us this opportunity.
Thank you, Alan. That's Dr. Alan Sese. Perfect. So we can see everyone.
Now you can see everyone.
Yeah. How to... Can we put there your... Perfect.
So you only have one, top 1, right?
We have 2 screens. You're going to scroll to your right because the group is very big.
The group is big.
So you got to screen to the other side unless you have an 80-inch television in front.
I have.
Oh, you have? Okay. Then you can actually have it all.
You see them all, Rolf?
Yeah.
See? If you have a big, you can actually see all of them in.
Hello.
Hey, Alan, why do you have 2 pictures?
Yeah, we'll have 2 pictures. Arlene, can we have a group picture? Maybe take 2 times. There are 2 pages. Hello, everyone. Thank you.
Hello. Hello.
Okay, take a picture. And then the other one. Can you turn on your videos?
Ocampo is not turned on.
Pankaj is a room.
Filemon Tito Monteros, Jane Ricabolda, Gerardo Gonzalez, Ahmed
Tito, Jane.
Boji. Boji, it's your picture. Hello, everyone. Thank you. Joseph Lim. Hi, Glomar. Hello, everyone. Okay, good. Dr. Ocampo, Hernandez.
Where's Chris? Oh, there.
Okay, good. Next. Perfect. Hello, everyone. Good. Take a picture. Arlene. Perfect.
दोनों आ गए पहले वाले में मेरा फेस कट रहा था तुम्हारे वाले में.
So who will announce?
Can we post now the score, Arlene? Okay.
Anil, that is your honor.
Oh, sorry. What do you expect from me?
To announce the winners.
The winners.
Oh, that. Well, Rolf does that normally. Is Rolf there?
Yeah.
Yeah.
Yeah, Rolf. That you are the one handing out the live memberships, man.
So I can see if we take the 3 best, it will be 5 best.
Yeah.
1, 2, 3, 4, 5.
1, 2, 3, 4, 5.
So
Yes.
Johan Abraham, Ralph Kabadou, Joel Celage, Armen Posadas, and Carmen Bragais.
Congratulations.
These are the 5 top. There is one who had all questions answered correctly. I think he should get 2 memberships. Double life membership.
Very good.
Double life. Very
so
good.
Congratulations to those 5. Normally we give 3, but here we can see that it wouldn't be fair to divide the group of those who have answered 25 questions correctly.
Agree.
Congratulations. Anil, anything? When do they get their certificates? Membership certificate.
Yeah, they will have to, in fact, write to Pankaj here at the Secretariat, and Pankaj will then forward their names to the Singapore Secretariat of APHS, and they will get their life memberships from Singapore.
So Pankaj will take over and send it to Emma, or how does it work?
Yes.
Pankaj, are you there? You are muted.
Yes.
We have their emails, right? So we give the emails to Emma.
Okay.
At the Pankaj.
Yeah.
And then Emma will issue them their certificates from Singapore.
Yeah, somebody needs to send their mails to Pankaj, and then he corresponds with Emma for their life membership certificates. Okay, all done. Thank you very much. Thank you.
Don't forget the feedback.
Thank you.
Thank you.
Thank you, Ken. Thank you for doing this.
Thank you.
See you next time. See you for part 2.
Thank you.
Thank you, everyone.
Thank you, Dr. Allen.
Of course, we will come to the Philippines for part 2.
Yeah.
Thank you. Thank you. Thank you very much.
Thanks for your invitation.
Alan, thank you.
Thank you. Thank you.
Mas Alan, thank you.
Maraming salamat.
Thank you to everyone.
Salamat.
Once the lockdown opens up, I'm keen on opening up the anatomy lab, and we will do the cadaveric part 2.
Yeah.
Once it opens up also, we're running a fellowship program. We have 3 government hospitals. We can offer the preceptorship program in all our hospitals. So we have 3 big government hospitals, and we will welcome Filipino participants and even foreign participants. Thank you.
Thank you, Dr. Allen.
Thank you. Thank you. No, we need to thank Asia Pacific Hernia Society and the Hernia Essentials program, headed by Rolf Hartung and Anil Sharma.
Anil. And thank you, Medtronic, for the support.
Thank you, Medtronic. Linda, thank you. Bye-bye. Bye-bye, everyone.
Bye, everyone.
Thank you.
Bye. Bye. See you later.
Bye. Congratulations to everyone.
Bye.
Perfect. cut off. Very good.